taranaki maunga, tenei te whakaatu nei te aroha ki au koutou. Haere mai, haere mai, haere mai rā. Koutou hoki nā ngā rangatiro o te nai nei, ngā rangatiro mua pōpō e kaha nei ki te whaiwhai haere tēnei taonga o tātou, ko te oranga o te tangata. Hea te mea nui o tēnei ao, he tangata, he whenua, he wai. Nā reira tēnei ka mihi ati kia tātou. Hea tīmata i tau tātou wiki, i roto i te haumaru, i roto i te papairawa. Nā reira tēnei e whakatoa te wahanga, kia hanga nei i ngā rangatiro mua pōpō, ko koutou tēnā. Nā reira kia kaha, kia maia, kia mano nui tātou i roto i ngā mahi, mo te oranga o te tangata, te whenua, me te wai. Kia hoki aku kōrero, kia koutou hoki rā e ngā mārei kura ko tai mai. Nes, āmen e kia koutou, āmen e kia koutou. Nā koutou, te pūtea tau toko, he manaki nei tō tātou kaupapa. Ia tau, kei te mihi, kei te tuku aroha atu kia koutou. Hoki aku kōrero ki tō mātou tumuaki o kōnei, e a pāpārangi. Tanera rātau anō, e kaha nei ki te whawhai haere, mō tātou, te iwi Māori, tēnei te mihi, tēnei te mihi, tēnei te mihi. Kāre te toro hoki i ngā kōrero e aku rangatira, kia tātou, he waiata ki te here mai, ki runga ki te tae tātou ki te waiata tahi. Nā reira. Tēnā koutou, ka tira, kia ora mai tātou, katoa. Tātou e, nārera tēnā koutou, ka tira kia ora mai tātou katoa. E tukuna te wahanga kia koe te pāpara e boi. Ei te mihi.
Thank you, Tēnā koe kamatua toi, mō te karakia, mō te mihi. Kia ora ki kaurua, ngā mihi nui. Dolly and Julie have supported us every year for as long as I've been doing PHI Week. Ki ngā tau ira, kia tātou katoa i tēnei wā, tēnā koutou, tēnā tātou katoa. Kia ora koutou, so I'm Boyd Swinburne. I've met you before, I'm sure, at the beginning of the year when we talked about what PHI Week is all about. I'm just going to, before we get into the program per se, I just want to give a few minutes to some good colleagues of mine. I sit on the Maz Foundation board, and with us today we have Julie Whakawera-Mika and Mafi Whanaki Tahi-Forte, and they are the co-heads of the Maz Foundation. So Maz is the medical assurance that some of you will be familiar with, and you're probably members, and it runs a foundation. So I'm just going to give Julie and Mafi a few minutes to talk about their work, because actually the work that we're doing this week on thinking about big, tough public health problems which need upstream solutions and need funding for them, the Maz Foundation is in this game of a philanthropy trying to influence upstream causes of health problems. So I'll just hand over to Julia Murphy. Thank you. And we can get your slides up here. Oh, it's down here. It's already done. There we go. Kia ora.
Kia ora. Ata mari e tātou, tēnei te mihi nui, ko Julie Wharuiramika, tōku ngā he uri au ngā te awa ngai tūhoi me te whanapanui. My background is working in the mental health and wellbeing sector for well over 20 years. I'm a clinical psychologist, kaupapa Māori researcher, and 3 days a week I have the privilege of being the co-head of MAS Foundation alongside my colleague Muffy. Our sons were friends before we met. They're med students, probably some of your mates. So we feel as though the stars were aligned to bring us together to work on this very important kaupapa. Kia ora.
Kia ora koutou, mā tau mai bongbongini, ko kuingoa ko mawhi whunaki tahi whote, and I hail from a small little kingdom of the island of Tonga. I have been in Aotearoa for a couple of decades. My background coming into the foundation, same as Julie, as a health worker. I'm a dietitian by background, so I do 4 days a week for MAS Foundation and do 1 day clinical and in the nutrition space, and do work alongside Boyd in that space as well. And just shout out, yeah, I've got a son in the class, probably online, and also my nephew right here on the left. So kia ora koutou.
So you might know a little bit about MAS. So MAS is the insurance company that was set up for doctors, established well over 100 years ago. And in 2018, the members, who are owners of MAS, decided to set up a philanthropic arm, a charitable arm, to address issues that were faced in the health and wellbeing sector of Aotearoa. In 2019, they formalised the foundation, and then in 2020, they were set up.
Yeah, so in 2021, just after COVID, Julie and I came into the role. Prior to our role, it was Dr. Emma Laurie, who was the head of foundation. There was a position statement around te tiriti o Waitangi. So the foundation looked at having heads of foundation in the role, a te tiriti partnership role. So we started March of 2021. And every year, as you look, we've got MAS Foundation and we've got MAS. So our annual distribution comes in from MAS. So when MAS has profit, it gives the foundation the funding to actually distribute out. It started off with 1 million a year. So luckily, last year it was a really good year for MAS insurance. So we've got a bit more this year.
So in total, from the end of last year, MAS distributed over $9 million to supporting health and wellbeing and equity in Aotearoa. And I should mention that alongside Boyd, we have amazing trustees, including Professor Martiri Howard and Dr. Carrie Bryars. So we have some amazing brains that advise our strategic direction to how we invest. What's happened that's really special towards the end of last year is that we've decided to really hone in and refine our investment approach. And we're looking at investing into te tiki a Taranga. Taranga being the mama of Maui, and tiki the top knot. So we are very much investing in the early years.
And this didn't come out just out of nowhere. Inquiries that we get from the foundation, Julie and I had worked to look at theming those, and that's how the inquiries came to the theme of Te Tiki Taranga, or early years. One of the values of the foundation, which we'll cover a bit later, is around getting the voices of community, and we're responding to that. So it is not from our end and from our Board of Trustees, it is the voices of the communities that we serve.
So just a little bit of an overview about our vision, our mission, what we're driving towards, but really importantly, we wanted to highlight the values of our foundation. And they were set up collaboratively alongside our board, alongside our kaimahi, and this is the criteria we use when we're investing into initiatives, into different kaupapa, different proposals that come our way. So we're wanting to be really bold, brave and steadfast, step out of the comfort zone, so really challenge the boundaries of our current health and wellbeing system, doing what's right and fair and just, so we really recognise that a lot of solutions can be led and advised from a community grassroots level, and weaving people together. We recognise that we can't address these challenges alone, that there's a collaborative approach that's needed.
Yeah, so as Julie said, these are really key to guiding us as heads of foundation and also the trustees when we do get inquiries around funding. Do they actually align with those that are the purpose and values and vision of the foundation? So this is just example of, on the right, some of the, we call it ringaraupa, or those with callous hands. So these are people who are actually doing the work, and they're out there. So we do give them, our kaumātua had given them the kopu of ringaraupa, and it's on the right. But in addition to the vision, mission, and values of the foundation, these are also the principles that we do look through in terms of funding or granting in the space. First, por te tiriti, are they aligned with te tiriti o Waitangi? Are they led by Māori? Are they led by Pacifica? Those are our vulnerable populations when we're looking population health-wise for Aotearoa.
So addressing inequity is part of our business, so really understanding from a community perspective, what do they think are the inequities that they want to address within their community? So understanding community aspirations and really taking that on board to guide the way that we want to invest, understanding the intersectionalities that exist within the communities that we're aiming to serve as well. And equity of system, you would have heard or be hearing a lot about this from Boyd throughout the week. How do we start to influence systems for long-term sustainable change? So that's part of our core business. Recognising the investment we're making isn't just for here and now, that we're looking into intergenerational shifts. I just wanted to highlight the community groups that we invest in. Like, this job is a dream for us. Like, we love coming to Mahi. It's such an awesome opportunity to connect with community groups doing amazing things and making a big impact within their own local communities. Taku Māmia is based in Hastings. It's a marae-based early years kaupapa, antenatal, postnatal care, and we've provided some support to connect them to clinicians. They have paediatricians who come in to improve accessibility within their marae community.
Pepi Pena Pena is to empower whānau and mātauranga on Māori knowledge. They have updated their website, so do visit them. They've got a lot of videos about mātauranga Māori and raising our children.
Perinatal Anxiety and Depression Association, you may have heard of them before, an amazing kaupapa. They held an awareness week a couple of weeks ago and ran a wānanga at Papakura Marae, and we were privileged to attend that marae, and we heard about how they're creating a new workforce of peer support lived experience and connecting them into the current clinical expertise as well. So it was really inspiring to meet the amazing wahine toa who are leading this kaupapa.
Yeah, and the last one here is Kakala Mālia Incorporated Society. If you visit Otara, you would find Akoteo Katukakala Early Learning Centre with Dr. Jean Te Sina. They went on to doing a whatu lālanga. So whatus from the heart, lālanga is to weave. And they weave in some of our Pacific cultural insights and in bringing our pepe and their children in the Early Learning Centre. So do visit if you're in Auckland at Otara.
Yeah, if you want to know more information about MAS Foundation, check out our website. Google MAS Foundation, it should come up as the first Google search. I also want to acknowledge Health Coalition Aotearoa, who we have had a long-standing partnership with, which Boyd is one of the co-leaders of. Tēnei te mihi nui. Mālo.
Thank you so much, Julian and Mafi. So as you're preparing your project for presentation later this week, just imagine that you're sitting and having to present it to these two amazing wahine and another board, a row of people scrutinising your project. Okay, I'm just going to take a few minutes just to tell you about today. So I'm just going to go through what we want to achieve, and I mentioned this in January when we met, but I just want to go over this again. We want to expose you to a different way of thinking, a different way of thinking, and a very complementary way of thinking to the clinical work that you have been doing. Thinking upstream, the determinants, causes of the causes, thinking of groups as well as one-on-one. Prevention, promotion, protection. You'll hear a lot about that, the fence at the top of the cliff. Inequities that Julie and Muffy have already talked about it, that drive the inequalities that we see in health outcomes. The environments which determine our health behaviours. You know, we're not islands to ourselves, we're highly dependent on our environments, and thinking in terms of systems and policies which create those. So it's a switching of thinking, it's a different way of looking at health through the eyes of the population and society itself. So this is what we want to achieve in this week, being able to articulate a population health approach and understand what happens with policies and programs and how they try to address the determinants of health. We have to apply those to a specific health issue that you've been given, or a specific issue actually, like it might be housing or climate change or transport, which is not directly health but has big impacts on health. And so all those societal factors play out in our health statistics. You'll be meeting a whole bunch of community agencies, which you otherwise wouldn't if you're working within the walls of the hospital, and to understand all their mahi in the community and in organisations in trying to improve the health of New Zealanders. And looking at how we provide health funding sources, access and the success of health improvement. We're also going to talk that middle dot point about how population health and personal health approaches complement each other. So that'll be the next session after the break. So we've had our mihi and welcome. We're going to shortly hear from Michael Baker with his keynote presentation, and we'll have Q&A. There are people online, and are they going to send their questions to you? Is it Anna?
There should be a live chat function.
Live chat function on the Zoom?
No, on YouTube.
On YouTube. And are you monitoring that?
No, I'm not sure that's working, but yes.
Whew, okay. Maybe before Michael finishes his talk, we'll have a way for the people in the regions, because we're beaming this through to the regional students out there. Saia, if you're listening, you're not a regional student, you're an Auckland student. He was supposed to be here, right? He didn't want to come, maybe because his mum would call him out. Anyway, I've decided to call him out anyway. Then, after a break, we've got the panel discussion. We've got 3 clinicians. Oh, I didn't change Dr. Owens. We've had a bit of a change in this, I'm afraid. Dr. Owen Sinclair's at the last minute hasn't been able to make it. So we have Professor Sue Wells, who's Professor of General Practice, is going to stand in instead of Owen Sinclair. So we have Almea Herman and Sue Wells and Dr. Nina Sue. Then we'll have a break for lunch, and then you'll hear from me. We'll have an hour about getting into depth about the whole week. And then at 3 o'clock, you'll be meeting with your group facilitators. Hopefully most of these will be face-to-face to sort out the group and learn about your project and orient to each other. Then tomorrow morning we have Population Health in Action. Tuesday, Wednesday, half of Tuesday, Wednesday and Thursday, you're meeting with agencies, researching your topic, pulling your project together, and then we present the program on Friday, your pitches on Friday. Each day at midday, I want one person from each group to meet with me online when we go through how things are going with your group, and you can hear from others as well. So, kia ora. With that, we'll have a more detailed rundown in the... is this you, Michael? We'll have a more detailed rundown at 1 o'clock. But now I'm going to call upon Caitlin Jardim. You with us there, Caitlin? Oh, you're sitting right up the back. Okay, come on down and introduce Michael Baker.
Morena, everybody. Today, I'm pleased to be introducing one of the most influential voices in recent public health. Michael Baker, Professor Michael Baker, is an epidemiologist and Professor of Public Health at the University of Otago. When COVID-19 emerged, Professor Baker was one of the first epidemiologists globally to advocate for complete elimination rather than just slowing transmission. In the peak of the epidemic in 2020, he shared evidence-based information, giving over 2,000 interviews during the pandemic, and using science communication as a form of advocacy. His efforts saw him win the Prime Minister's Science Communication Prize and recognition as a member of the Order of Merit. But beyond COVID-19, Professor Baker has been a public health pioneer for decades, helping to establish the world's first national needle exchange program here in NZ. Please join me in welcoming a scientist who has demonstrated that a commitment to collaborative research and advocacy can save lives, Professor Michael Baker.
O tēnā koutou katoa, no te whanganui atara aho, ko Michael Baker toko ingoa. Thank you, Caitlin, for the lovely introduction. Thank you, Boyd, for the invitation to come and join this week. And I was super impressed when I found out about the Public Health Intensive Week and just the incredible tasks that you have to do very quickly. So I'm hoping that some of the things I say today might give you some ideas, certainly about the particular health problems that I'm going to focus on. So the whakatoki he waka eka noa, I think, summarises for me a lot of the features of public health. We're all in it together. And I'm going to start by taking us back to early 2020, a really critical month, March of that year, when New Zealand went from the pandemic is going to wash over us like influenza has done in the past to we're going to stop it. And I had this really strange, quite surreal experience where my friends of mine in Wellington, playwright Stuart Mackenzie and Miranda Harcourt, they used verbatim as a method for capturing critical events. And so they interviewed 3 of us and May Heron, so there were 4 people interviewed for this play called Transmission. And I'll just show you a little excerpt from that play.
I am speaking directly to all New Zealanders today to give you as much certainty and clarity as we can as we fight COVID-19. Over the past few weeks, the world has changed, and it has changed very quickly. This is because we are experiencing an unprecedented event, which in New Zealand we have moved to fight by going hard and going early.
I understand that all of this rapid change creates anxiety and panic, especially when it means changing how we live.
That's why today I am going to set out for you as clearly as possible what you can expect as we continue to fight the virus together.
We have to focus on one simple goal, to slow down COVID-19.
Slowing it down means not having one great tidal wave of cases, but smaller waves, groups of cases that we can manage properly as they arise.
This means we will reduce the impact on health, on jobs and on our economy.
Today I am announcing an alert system for COVID-19. There are 4 levels to the alert system.
Alert level 1 is when COVID-19 is here but contained.
Alert level 2 is when the disease is contained but the risks are growing.
No. Alert level 3 is when we restrict contact by stepping things up again. We close public venues and we ask all non-essential businesses to close.
No.
And alert level 4...
No, stop! They presented this 4-level alert system to the technical advisory group, which I was on. And it was basically saying that as the pandemic escalates, you move your way up the level of controls to the unthinkable, being lockdown, level 4. And I remember looking at this and saying, but that's the wrong order. You don't work your way up following the pandemic. You start at the top and you work your way down. Because this is a disease we need to eliminate. I realised at that point we just had to shut the whole country down immediately. We shouldn't just throw the kitchen sink at it. We should throw the whole house at it. And everybody there just looked at me like I was a complete madman.
So it was a year later, we were still basking in the, the success of elimination before the alternative narratives were starting to emerge. And so everyone was still very optimistic at that point. And the strategy, I'll come back to this, was highly successful according to all the metrics we use in public health. So today I'm going to talk about a few epidemiological concepts. I'm sure you've heard many of these before. And I've got just two messages today. One is that the public health approach can transform the health of populations and patients. And I think it's really, Boyd has said this as well. I'm going to say it again and illustrate it with 5 different examples of epidemics and pandemics that I think each illustrate a different response. Public health, addressing social and commercial determinants, improving global health security, and really how science fed into the elimination approach. And the second theme is about finding your voice, speaking out. And many of you will have opportunities, all of you will have opportunities to do this during your career. So I'm sure you've heard many definitions of epidemiology. I always think it's a science of preventive medicine, thinking about who gets sick, why, how can we prevent it, how can we improve health, how can we alter exposures to hazards, the wider determinants of health, healthy environments, and promoting equity. So all of these concepts are in there in that definition. But I also think one of the things I've learned over time is that you have these two opposing forces. At one level, life is deterministic. So it's somewhat predictable. I'm sure Boyd, I'm taking words out of his mouth here about smoking and fruit and vegetables and so on. So that's one element. That's what we're always promoting, but we also accept that life is stochastic. Shit happens, and we see examples of that, and both on the positive side and also happy accidents. I'm mentioning twinning for 2 reasons. One is it's still an entirely random phenomenon, and that's monozygotic twinning across all populations. It has not changed historically or geographically or by age, unlike dizygotic twinning. So it is a purely stochastic phenomenon. And also because I am actually an identical twin, and I had this experience of growing up as part of a cohort study of 2, and my twin is actually a GP in Sydney, so we can compare notes about the population and the patient dimensions. And so I went through Auckland Medical School. I used to spend many, would I say, happy hours in this lecture theatre, many hours in this lecture theatre, and then trained in various hospitals around the Auckland region, including spending a year at Northland Base Hospital, which I really enjoyed. And I lived in a typical Auckland flat with my 20 flatmates in Parnell, and it's still going strong, the big house in Parnell. And I'm going to now run through these 5 examples. And when we talk about, in your life, you have these stochastic things that just chance events. And when I was still looking at registrar posts, an old friend of mine was working in the beehive, and he said, the minister had a good experience of a junior doctor in his office and wants a replacement one. I think the last one got burnt out. So I wound up, I thought, I'll have a year out working in Parliament. And of course, it was a complete shock because I had no idea really about the population dimension, how decisions were made. I barely knew there was a Department of Health. And so I became a non-political advisor for Michael Bassett. And in that 4th Labour government, before it kind of fell apart in its 2nd term. And by chance, the other huge event at the moment, at that point in time, was that HIV/AIDS was hitting the world, and people forget how horrible this and scary this disease was because there was no treatment, and if you developed AIDS, you were almost certainly going to die, and that took a few years after HIV infection, and you had these rising epidemic curves, and New Zealand imported some ads from Australia. They had the Grim Reaper, and they had a bowling alley, and balls were going down the bowling alley, and they were knocking over people, actors like Skittles, and it was showing that the virus was going from who were the kind of guilty people who were infected because of their behaviours, and it was crossing over to the innocent people, everyone else. And so one of the consequences was that political parties were very keen to agree to anything they thought would slow down this virus. And so Another thing also arrived at that point, the Ottawa Charter for Health Promotion, which I still think is a wonderful framework for thinking about how to respond to population health issues. I'm sure you've come across this many times, and you may be revisiting it this week in terms of how you frame your approach to population health issues. I still find it, I mean, this is many years later, 40 years later, it's still a very useful framework. So there was real concern about explosive epidemics amongst people who shared needles and injected drugs, and this was an illegal behaviour. It was illegal to possess needles and syringes. So I did all the policy work around setting up a needle exchange program, what would be required, and there was complete bipartisan support in Parliament for this because of the fear of HIV. And so, and really very rapidly, this program was set up, and I was involved in its implementation. And I thought, wow, I really like the population health approach. So I switched to public health medicine, and I'm pleased to see you got a banner from for the New Zealand College. So I did the 5-year training in that field. And so looking at the program, this is the numbers of syringes distributed, and it's now millions of syringes a year. But the big thing that is the outcome, the impact it had. And this is showing new HIV diagnoses in New Zealand by year. And the group there, people who inject drugs, was small numbers initially, and basically it stayed small. And we've never had outbreaks in this population. So this was showing basic healthy public policy, creating an environment where people could get access to clean needles and syringes very easily. At that time was also, we saw a real transformation in human rights approaches and harm reduction. Homosexual law reform, Misuse of Drugs Acts, I've mentioned, the Needle and Syringe Exchange Program, Prostitution Reform Act. So all of these programs basically shifted the whole framing from being criminal activities to being a health concern, and really enabled access to communities who are otherwise marginalised. A second example I want to talk about is around the social determinants of health. One thing that we did this analysis is 10 years ago, but this showed really quite a big surprise that infectious diseases are the main reason that people get hospitalised in New Zealand still. There are over a quarter of hospitalisations. But the thing that, this is 20 years of data here, and it's showing that there was a surprise. There was a rise in serious infectious diseases in the 90s. They rose 50%. And that really shocked people. And I think this is one reason we got it published in The Lancet, is that no one expected infectious diseases to still be rising in a high-income country like New Zealand. And that was because the 90s were very bad for health inequities. We had the euthanasia budget and a drop in benefits. And it was pretty grim, and that, I think, trickled through into a rise in infectious diseases, which are a pretty sensitive indicator of inequities. But looking at, this is again looking at serious infectious diseases resulting in hospitalisation, you can see there's this very persistent ethnic gradient where Māori and Pacific people are more than 2 times more likely to wind up in hospital, even after you adjust for age. And the social inequities are also very large based on deprivation. So if you're living in the most deprived 20% of neighbourhoods, you're almost 3 times more likely to go to hospital with a serious infectious disease. And these inequities were not improving over that period. So moving on to looking at rheumatic fever, and I've always been very interested in this disease. It's one of many manifestations of Group A streptococcal infection, or Strep A infection. And this is, along with a number of other infections, this is one I've always been particularly concerned about, because you can see it has this huge range of illnesses it can cause. And these immune-mediated illnesses are still quite mysterious, how it causes acute rheumatic fever, rheumatic heart disease, and also glomerulonephritis. So it's our most iniquitous disease in New Zealand, and this is looking at your risk. By the time you get to 20 years of age, the cumulative risk for a Pacific child or young person is over 1% chance of having rheumatic fever at that stage. For Māori, it's about half that rate, but for non-Māori, non-Pacific, it's 2 orders of magnitude less common at that age. So this is a truly, totally unacceptable level of inequity. And so that, I think, has motivated now a lot more work on different approaches to try and eliminate this disease. And this is the kind of framework that we look at with rheumatic fever. And it's an unusual disease in that it involves every segment of the health sector in terms of public health at this primordial level, primary care, access to care, secondary care, treating ARF and trying to stop progression to RHD, and in tertiary care, this is valve replacements and so on. So it's really, when you go to a rheumatic fever meeting, I've just been at one actually, you have the entire spectrum of health expertise involved, and we're still failing with this disease. So this is another way of looking at the complex web of causality, but major social determinants of health are driving all of these pathways here in terms of crowding, access to washing facilities, health care, and so on. So, like all good epidemiologists, I did a case control study to compare cases and tightly matched controls. And these are the kind of risk factors that we found in that study. There's a family, it does have a familial component, but then we found these modifiable risk factors: household crowding, barriers to accessing primary care, high intake of sugar-sweetened beverages, so I'll need Boyd's help with this one, and preceding skin and throat infections. So there are so many opportunities to intervene here that New Zealand needs to really embrace. So I work with Hei Kāinga Oranga, the Housing and Health Research Program at University of Otago in Wellington, and there's a whole lot of initiatives in the housing area that I won't go into, but some of them are showing very promising results. Not so much rheumatic fever is too uncommon, but you can look at other hospitalizations and so on are significantly reduced by housing interventions. So a third example I want to talk about today is Campylobacter from dirty chicken, and this is around the commercial determinants of health and how they drive a lot of the health problems we see. And I mean, I'm sure you come across Campylobacter. Some of you may have experienced it at a personal level. It's not pleasant, but it's by far our most common serious foodborne infection. And with these symptoms, a lot of people wind up in hospital, sometimes have their appendix taken out, a normal appendix, because they've got this infection. The abdominal cramps are particularly severe. And we do see these sequelae of reactive arthritis and Guillain-Barré syndrome. So I remember I was working in the 90s at ESR, the National Reference Lab and Surveillance Centre for Infectious Diseases, and I was just noticing this rise in the rates of Campylobacter year on year, to the point it was getting to the stage where we estimated that about Wellington seemed to be the capital, or they have the highest rates, and we could, as far as we could tell, in the world, and it was getting up to the point where about 5% of the population was getting it every year. And I thought, oh, well, I'll just get data on fresh chicken meat production, and these curves, these lines, as you can see, are almost perfectly correlated. And you know the mantra, correlation does not mean causality, but in this instance it did mean causality. And so that was the observation. And many of you will make observations throughout your lives as a clinician or wherever you're working that you think someone should look into this. So published something in the medical journal, and then talked to the media about it, banned fresh chicken sales, birds dripping with disease. You know, there's always a bit of license from the sub-editors. And then there was the pushback from the industry. Michael Baker is an idiot. He owes New Zealand an apology. They're still waiting for that apology. Then, amazingly, there was a policy response. And one reason we got a policy response is that for a brief period in time, we had an independent food safety authority. And they said, oh, we need a strategy to contain this foodborne epidemic. And they put some monitoring of fresh poultry in and a regulatory limit. And then there was the impact. And we saw these rates of hospitalisation and notification both dropped exactly 50% within 3 months of this new policy. So that was really turning the tap down. It looked like a vaccine had been introduced, but it was just simply controlling the dominant source. So now, 15 years later or so, we have not succeeded in lowering rates any further, and we still have a recent high-quality case control study with whole genome sequencing showed that chicken is still causing over 80% of cases. And these are the kind of numbers of cases we're looking at: hospitalisation, deaths, economic costs. So this is a huge burden on New Zealand that is being ignored by the industry and the regulators. So this is resistance to further action. Lowering the allowable limits in fresh chicken could fix this. They even refused to have mandatory labelling on fresh chicken saying, oh, by the way, make sure you cook it properly. And the worst thing you can do is wash it under the tap, because that fires bacteria throughout your kitchen. And a lot of people will not know these things. So, of course, I'm a paid-up member of the Health Coalition Aotearoa at this point, because basically you have to look at the commercial drivers. Who's making money out of this and how they're lobbying? And admittedly, I borrowed this really from more of the long-term conditions area or chronic disease area, but actually this is where we do have a common interest. You look at lobbying and self-regulation, all these other familiar responses from industry. And one thing I would say, we could say this issue has been around the block of the policy cycle. So we think about, we did agenda setting, policy, decision-making, implementation, evaluation. We're back to the starting point. And many issues are going round and round the policy cycle where you try and fix things, but most things are never entirely fixed. So you get back to the starting point again. And really we have to look at what are the things that are maintaining the status quo here, even though it's expensive and harmful for our population. So the next example I want to talk about is SARS and influenza. This is bird flu H5N1, and how they really contributed to an improvement in global health security. And this term is around basically minimising the danger and impact of acute public health events, and it's across geographic regions and international boundaries. So this is very much the work of the World Health Organization. Obviously, what's not to like? We want these things to be happening. We used to have pretty dismal international laws. We had various conventions that applied right up to a fairly recent version of the International Health Regulations, 1969. It was still really not doing very much. It was dealing with with diseases that really were no longer the global health threats they'd once been. So then we had a couple of events, and one was SARS, and that was the first global coronavirus pandemic. Before your time, you probably don't really remember SARS, but for those of us working, this was quite frightening. It looked like it would transmit right around the globe, and it did to some extent. We got one likely probable case in New Zealand. But then it was found out it was actually quite containable for reasons to do with how it got transmitted and when people were most infectious. We also had a scare with avian flu in Hong Kong, and so all of this stimulated the huge upgrade of the international health regulations in 2005, and I was doing work for WHO on this process. And this was really the first time we had really good international law around how to manage pandemics. And it meant that it covered a wide range of different events based on risk assessment principles, and it introduced this new concept of the public health emergency of international concern. And so this was a massive improvement. And then, of course, it had its limitations. The first time it was really tested, the first fake public health emergency was this influenza, swine flu, and some of you may remember this in 2009, you've been through we've all survived our first global flu pandemic. And this was quite shocking in some ways in that New Zealand became one of the first countries in the world to see this pandemic and arrived on an aeroplane the same day the declaration was made, and it just reminded you of how quickly these pandemics can spread. We had a bunch of students and teachers on this flight. So the flight was sat at the airport, and then everyone got tested for flu and was followed up, and this transmission seemed to have been contained. But it did tell us that flu could transmit on aircraft because we saw transmission between people on this flight. And this was the pandemic wave, that this was the people on that flight there, and there was a bit of a delay, and then it started spreading very widely in New Zealand. Fortunately, this strain of flu was no worse than seasonal flu. So it didn't have the kind of mortality you saw with 1918 flu pandemic, which came through New Zealand in 6 weeks and killed 1% of the population. That's 9,000 people died very rapidly. And in today's numbers, that would be totally unacceptable. So this is the 1918 flu, and this was on the centennial of this in 2018. We thought we'd just try to promote the idea that we needed to still be prepared for pandemics. And this is my son's school. We got 440 of the boys to lie out in the field, which is quite difficult. And the photographer sent up the drone and took these photos. And so we put this out to the media. There was no interest. No one wanted to think about the 1918 flu anymore, or what a pandemic could do. And then a year later, there was this unveiling of the pandemic memorial. New Zealand had no memorials to the 1918 flu. It had lots of memorials, obviously, to those who sacrificed their lives in the war, as appropriate, but nothing really on flu. And so this was Jacinda Ardern and Jeffrey Rice, who'd studied the flu pandemic a great deal. And this was in hindsight, was quite an interesting date, November 2019. And I was there and I was chatting to a few of the politicians, and they were saying, oh, well, that's not going to happen again, is it? And of course, that same month, COVID-19 was starting to spread in China. So global health security, the many reasons you need it. The main reason is these spillover events, and that's almost certainly where COVID-19 came from, via a wet market in Wuhan. But there's also the lab escape theories. I think this is very unlikely in this instance. But labs have been the source of pandemics before. Russian flu in 1977 almost certainly came from a Russian laboratory. So one of the things that's been happening, and obviously COVID-19 has accelerated that, is the need to have much stronger measures to support global health security. And Helen Clark's really been leading a group very effectively to advocate for this. And so we've had these measures, the IHR revision last year, and now a pandemic treaty has just been signed. None of these things can totally eliminate the risk, but they can ensure there's a more effective response. So moving to the last example is obviously COVID-19, and I think this is where science has really made a huge contribution. And because I'd had a long-term interest in pandemics, I was looking at this quite intensely. There are obviously a lot of false alarms with pandemics. The first time you read about something, you have to be a bit skeptical. But we knew by the end of January 2020 it was going to be a serious global pandemic. There was no question. All the key parameters were already defined. And then I thought, well, we're going to follow the flu plan. That was our pandemic plan. It's going to wash over us, mitigation approach. But then there was this remarkable report from Elwood and Co. at the end of February saying it really had been stopped in Wuhan. And that had never happened before. No country had ever stopped a respiratory pandemic in history. So I became instantly very enthusiastic about elimination. And by March, of course, it was already circulating in New Zealand. So we, in addition to what you could call exclusion at the borders, because we had shut our borders at that point, you also needed to stamp it out. This is showing those choices you have with, in terms of response strategies. Most of the time, we don't do anything with pandemic viruses circulating the planet. Every winter, we get a new set of viruses that arrive. Generally serious diseases, we try and control them, reducing numbers. And we've got two approaches here. Generally, you're trying to suppress things like TB, HIV/AIDS. We're still doing that. We're not trying to eliminate them. Well, we will be able to eventually. But there's a special thing, mitigation, and that is where you get a new infection that comes like a giant pandemic wave and washes over the population. And then the idea is to reduce its impact so that it doesn't overwhelm the health system. So that was our pandemic plan. But we also are familiar with elimination. That's reducing to zero, and we do this for measles. We have, WHO has elimination strategies for a lot of diseases, just not pandemic diseases. And occasionally you get to eradication, smallpox or SARS. So we wrote and published, I think, the world's first COVID-19 elimination strategy. Basically, New Zealand made that decision on the 23rd of March to go to effectively adopt an elimination approach. Our leaders would not talk about elimination for about a month because they thought it sounded too aspirational, and it could easily have gone wrong. So this is what happened. We had an elimination strategy for almost 2 years, a brief period of suppression during the Delta wave, and then we switched to mitigation with Omicron, which is the variant that we're still living with at the moment. So this is what I think is still one of the most remarkable graphs. This is the number of people crossing the border into New Zealand every day. And pre-pandemic, it's a bit seasonal, there's about 20,000 people a day coming in. Suddenly it went down to about 500. Some days no one arrived in New Zealand. And that had never happened for about 50 years. They had to look through their old records to see when was the last day no one came. And we had a brief green zone with Australia, and then until that didn't work. And then we're back up, we're heading back up to those sort of pre-pandemic levels now. So what was the net effect of what New Zealand did? There are many metrics, but the one I think is most useful is cumulative excess mortality. And this is, that's basically looking at the before the pandemic, using that 5-year period as a baseline, and then seeing what happens now in terms of where excess mortality is going. And you can see that countries that adopt elimination approaches, Taiwan, Singapore, Australia, New Zealand, our excess mortality stayed down for the first 2 years of the pandemic, and as all of us opened up, it started to track back up again. But the net effect was a large saving of lives. And if you look at somewhere like the US or UK that had poorly managed pandemic responses, they lost, and 3,000 per million is about 0.3% of their populations died from COVID-19. So 100,000, more than 100,000 people in the UK, more than 1 million in the US. Of course, right off the scale is Russia, which managed to kill 1% of their population with COVID, more than 1 million people. So complete disregard for public health, which is probably fairly consistent. So the great thing about time is your friend in a pandemic, because it gives you time to get vaccines and roll them out. Also, you can treat people much more effectively. You learn how to do that. Rather than putting them on ventilators, you give them dexamethasone and high-dose oxygen in the general medical wards. So people did much better, unlike this terribly high mortality early on in places like the UK. But one other thing that isn't always talked about is that we had far fewer restrictions than other countries with elimination. And some of you will remember that you could have stadium events, apart from these brief pulses of stay-at-home orders. to stamp out the virus, New Zealand had, on average, far fewer restrictions than Sweden or the UK or the US. So, future pandemics, obviously, there are a lot of things that are to be concerned about. This is looking at going from low to high case fatality, low to high transmissibility. So this is the quadrant you worry about, and obviously flu pandemics are the most predictable, unpredictable thing here. Smallpox, if it was reintroduced, would be devastating. But emerging disease X, these are things that spill over from the animal world. There are a lot of things that can do this, but I think novel synthetic diseases are now a growing threat for lots of reasons. And so there's a lot of details there, but it's just saying that pandemics that are engineered by humans, there's now a lot of pathways for enhanced pathogens, novel pathogens, weaponized pathogens, and this dual-use concern, and gene-drive systems. So these are the kind of pathways that now exist, and this technology is now very available. CRISPR, gene editing, combined with AI, means that really, literally, tens of thousands of scientists around the world can do this. There's now 1,000 level 4 labs. That's where people go around in spacesuits and are dealing with very dangerous pathogens. So I think that this is a big concern. One thing I hoped that would come from the pandemic, particularly in the early phase, was we would recognise the ability by working together and how transformative that was. And most New Zealanders want a green recovery. We want a more equitable society. Unfortunately, we haven't, I think, translated that momentum from the pandemic period into achieving these goals. So the second thing I want to talk about is finding your voice and speaking out on these opportunities. And all of you will have opportunities to do this. So I found during the pandemic, I think I might be now up to 7,000 interviews, according to the university who does monitor these things. And after a while, you think you're starting to bore yourself, with what you're saying. It's just repeating these same messages over and over again, which you have to do. So one of the positives from the pandemic was that a philanthropist has funded us to set up this Public Health Communications Centre, which has now been going for over 2 years, and we're very pleased to have Boyd on the board for that. And this is the kind of numbers of briefings we're putting out. We're over 170 so far, and we can look at the some of the ones that create a lot of interest. Tobacco industry interference in the government meeting its international obligations, and work we did on long COVID, pointing out this actually is a serious concern. So if any of you are interested, this is, I'll add to your list of homework. You can sign up on the PHCC website and you'll get this sent to you. Be very useful this week. So one of the things we know, we're now battling misinformation, disinformation. These were some of the bizarre images from the occupation. There are many bizarre images. But these women there, they were saying, oh, we have to pack up and go home, because they were wearing the foil helmets because they thought there were rays being beamed out from the beehive that were going to damage them. And they said, oh, we have to go home now, because they'd stripped the local supermarket of its supply of aluminium foil. What's this about? Make influenza great again? I just don't get it. One thing is we do need to protect our messengers because they can have negative effects from speaking out. And this, I think, is such a poignant story. I mean, many of you will have heard of Semmelweis, who was really the first person who developed ideas about asepsis and hand washing. And this is one of those famous stories. This is prior to the germ theory, which hadn't quite arrived in the first half of the 1800s. But he noted that there were two groups delivering babies in the hospital. There were the doctors and junior doctors and the midwives. And he noticed that the rates of sepsis were much higher in women who had babies delivered by doctors. And he observed that doctors, their morning routine would be to do autopsies before they went to the clinic. So he just introduced hand washing, and the mortality rate plummeted. And at that stage, the dominant theory was miasma, bad air, no idea of antisepsis. And he really struggled to get his findings accepted. He was alienated, lost his job, developed mental illness. It wasn't quite clear what it was, admitted to an asylum, and died 14 days later from sepsis as a result of beatings he received from the staff there. So he is now memorialised with a medical school named after him, and is a hero, of course, from that period. So none of us want that kind of outcome. But we're still battling with the need to be able to speak out on health issues. And this was a recent response from our health minister towards public health people speaking out on local issues. I have to say, over the last 5 years, I've had so many quite bizarre forms of response. This was a strange one, waking up and seeing my physog on these billboards all around the country, put up by Voices for Freedom. They're a US-funded group in New Zealand pushing back against vaccination. The traffic light system was only designed to nudge people towards vaccination. I mean, it's hardly the worst thing I've ever said in my life. And it sounded even a bit pro-vaccination, so I don't quite get why they chose that. Another thing I think is a bit disturbing is identity theft, and this is happening more and more, where your image is used to sell a fake product, various things for circulatory disease and erectile dysfunction. And so I was giving endorsement to all of these things. And actually, it's very hard to get these things taken down. And NetSafe will talk to Meta and can eventually get them removed. But one thing was people would ring me up and say, oh, thanks for endorsing that product. I've sent off my $350. And I'd say, no, get your money back. And often they could if they got it early. So it was hurting people. This is another quite a bizarre one, is that someone set up a fake Twitter account with my photo and name, but in the fine print was Michael Faker. And this person put out 12 tweets a day for a year, and they'd start every morning at 5 a.m., go to 9 p.m. at night. One of my colleagues did a quick analysis of these things and found that there was only one time he went every day of the week except for this one window on Sunday mornings from 10 till 12 when he didn't ever post. I don't know what was going on. But then he was taken down eventually after we complained quite a bit. So we are working with the University of Otago on policies to protect people who engage with the media. And one thing is just to recognise that by far the biggest consequence of speaking out on things is just the workload and the site stress of responding, and sometimes being a bit frustrated with media coverage. Generally, it's very good. These other things of unwanted, serious or extreme consequences are very rare, and we just want the university is now setting up a single point of contact. I'm not sure what, I'm sure Universities in New Zealand is trying to encourage all universities to actually protect people who speak out. So one reason that you should speak out is that you are the most trusted voices in New Zealand. This is a recent survey we've done, doctors and scientists. So you are in an incredibly strong position, and you can really use that opportunity. Other groups, obviously, not quite so trusted. Down here, politicians, which some other groups. So one thing about public health success, it may not always be very visible. So this is all right. But apart from better sanitation, the medicine, education, wine, public water, irrigation, roads, the freshwater system, and public health, what have the Romans ever done for us? And of course, Life of Brian has many key messages if you haven't seen it. And we have the equivalent in public health. We say, a public health triumph, nothing happened. And that's the success of prevention. It's also the curse of prevention, because after a while, people can say, well, nothing's happening. We don't need those people to do that stuff. It's also the problem of civil defence, all of these services designed to make life safer and healthier. So while I've got a captive audience, I just mention a few other things I think are important. You can look down that list. Obviously, the sense of humour. When I was training and a junior doctor, we all looked at the House of God. I don't know if that's still read by you. It is. And of course, this is going to hurt. Some of you may have heard Adam Kay just did a national tour recently. Again, a very interesting take on the practice of medicine. One other book I read recently that I found was very good was just this reality check, 4,000 weeks. That's what we've got, basically. And his take-home messages: stop trying to clear the deck, think of your life in terms of these domains, and embrace the joy of missing out. You can't do everything. So it's quite a slightly different take, perhaps. So these are my two main messages. Again, consider public health opportunities. They are transformative. We have so many examples, and I think you've got a wonderful week ahead to look at how you can contribute to that thinking. And the second thing is, you've got a powerful voice and you can use it in many settings to speak out on these opportunities. And I think He Waka Eka Noa is still a wonderful whakatoki that we can all live with. And I just want to acknowledge my many teams I'm working with, the Public Health Communications Centre, big team on rheumatic fever, and my department in Wellington. This is about half of them. Thanks.
Excellent, excellent. Thank you so much indeed. Maybe I'll take one of these. Turn it on. All right, well, is that working? Hello. I'll try this one. All right. Maybe I'll try this one. So we've each got a mic. Righto, folks. Thanks so much for that, Michael. Boy, if you guys haven't got 1,000 questions, then you're in the wrong place. This is a fascinating trip through Michael's time in public health. He's still got a lot to contribute, of course. And those of you doing rheumatic fever and foodborne diseases and vaccine-preventable diseases, you've already got a leg up from Michael about some thoughts for this week. Right, so people in the regions, I hope you've found a place where you can enter. What's that? You've got a what?
A novel.
A novel question. Okay. Huge. You've got a whole pile of questions.
No, one question is huge.
One question is huge. Okay, you'll summarise that question. People out there in the regions, could you please send your questions through, and Anna will translate them to us. While she's just shortening that question, we'll come to you in a sec, Anna. Have a think of your questions, folks. I'll take any questions or comments from the team here. Guys? All right, just to get you warmed up. Can you summarise that one? Ish, okay. Summarise it.
Okay, this is from Araha Scott. So she's talking about while the pandemic response is often celebrated, the New Zealand response is celebrated, and the MIQ policies left thousands of New Zealanders, including Māori, disconnected from a whole, groups of people, important people, caregivers, whānau, stranded overseas, others affected, including working class, disabled, migrant background, like that, stuff like that. The High Court, she says, found that aspects of the system unlawfully breached Section 18.4 of the Bill of Rights. So the fundamental question is what accountability exists for the inequitable harm caused by that, especially when access to MIQ disproportionately favoured those with wealth, digital literacy or political influence?
All right, great question. Michael.
It is a great question, and you know we've now got, we've had the Royal Commission of Inquiry, which reported last year. We've got phase 2, which is working its way through this year, that is very much focusing on, I think, the harms of the pandemic response, and they'll report next year. I'm actually going to I've been summoned to give evidence to them next week, so that'll be interesting. But the broad idea, one is the high-level concepts, the other is implementation. So you've got strategy and implementation, and both can be flawed. The other thing we always think about is counterfactuals. So the counterfactual is not no pandemic. Counterfactual is a badly managed pandemic or well-managed pandemic. So I think the evidence is that strategically New Zealand did the right call, but because it was much better than the alternative as far as we can tell. But the other thing is, when it's implemented, there are huge problems, and we could see that. I think the government tried to address some of the equity concerns with various forms of income support, but undoubtedly the pandemic worsened inequalities for people in New Zealand, or the pandemic response. So all I can say is we need to learn from that, document it, and do better next time. And so hopefully we'll have a far more effective pandemic plan going ahead. So that's learning. It doesn't make it any easier for people who really suffered badly. And I think there were numerous forms of inequity and injustice that occurred during that period.
So it does come on to some of the stuff you were talking about with the interaction with the political side. First of all, with your time in Michael Bassett's office, and then in these advisory groups that you've been on, and the New Zealand Food Safety Organisation and things that you've been on. And the politicians have to weigh up multiple factors, right? We're giving them advice on the health and the medical side, and they have to bring that in to a whole bunch of other factors to weigh it up. So I'd appreciate just a little bit more kind of insight into how those equations happen for the politicians from your experience, because they're the ones that make the decision, not the doctors.
Yeah, and I think they've got the really hard job, because they are elected to make these difficult trade-offs. And while we can often make a case from a health perspective, and hopefully we think about equity and other considerations, that's only one of many factors they're juggling. So I've got huge respect for the electoral system. They are elected, in a sense, the voice of New Zealanders to make those hard calls, and I don't think it's easy. I do remember something from the very first lecture I ever had when I did my public health training was a medical sociologist that I think was very wise. He said, "Today's solutions are tomorrow's problems." And it really stuck with me, and I found that quite hard, because it means that everything you do, and I think there's an analogy with clinical medicine as well, we always must remember the potential for adverse effects. And I think it's true, and obviously at a population level, those adverse effects get multiplied. So I think that's a fact of life that we need to keep thinking about.
All right, questions, folks? I'll repeat them down here, yeah.
Perhaps building on the last topic, if we were to face a similar pandemic to COVID again, what would you do differently?
I think shut the borders much faster, among other things, because it's much easier to keep a pandemic out than it is to stand it out in a country. So while we say elimination, we also include in that exclusion. And many Pacific Islands did that. They never had a single case until quite recently, because they just kept it out. They couldn't really manage a local outbreak. So that's one thing. The other thing is, I think we'd want to be a bit more nuanced about vaccines, because when the vaccine arrives, we're all a bit gung-ho promoting vaccines, but we don't always know. We only know from the trials that the vaccine is effective and safe. We don't know about some of the other things, such as does it stop transmission, for instance, and how long will the protection last for. And the COVID vaccines were not great at those things. So again, the limitations. So I'd say just keep talking about, we often think it's the fine print, but the fine print's important. I also think we haven't been very good at, I think our main health agencies have not been very good at just talking about some of the successes. For instance, we've got very good adverse event surveillance. It's showing these vaccines are very safe, but they just wouldn't talk about it. I don't know why. So there are a couple of areas.
But just on that, Michael, the tension between all the uncertainties that were coming out, or the huge amount we didn't know about, versus the need for clear and simple messages for the population to respond to, where all that nuance that you like, that we love as researchers, goes out the window.
Yep, absolutely agree. And yeah, in a sense, they want headline grabbing, they want to reduce things to headline grabbing titles, and unfortunately have become more clickbait focused. So even though you might have quite a nuanced story, it may get reduced to a heading, which is the main thing people see, that doesn't really reflect the complexity of the issue. So this is an ongoing challenge as a science communicator.
Any other questions, guys? I've got a couple of thousand here. Michael, one of the things that was fairly critical in our decision to close down with COVID was our lack of ICU beds, right? Our system here with very few ICU beds per head of population compared to OECD countries left us highly vulnerable, right? So do you want to talk a little bit about our readiness around the health care system to deal with the pandemic and how that reflects into the population health response?
Yeah, I think that's part of your counterfactual. What happens if we followed our mitigation plan, which would have been easy? That was the plan, and the virus washes over us. I think it would have been devastating. Partly we just didn't know how to manage people who are acutely ill from this infection. And talking to colleagues in the UK who are at the front line, they just watched even some of their colleagues who are middle-aged doctors getting infected and dying from this infection. There was very little you could do for people. And actually, most people didn't survive being put on a ventilator. It was really shocking case fatality risk. And that was just because of a lack of knowledge. I think of another example at the moment with avian influenza. The world can get enough vaccine to vaccinate everyone within about 6 to 12 months. So if you can keep that virus out for that amount of time, it's going to it's going to be incredibly beneficial. So I'm hoping that would be part of the thinking in the future. But, this is in the end a political core, and in some ways we want to shift it from being dependent on party politics or what government's in to actually a far more technical approach, where if something reaches certain thresholds, then it will activate a predetermined plan. And also that we use things like citizens' juries to meet in the inter-pandemic period to reflect the views of the public about quite complex issues like shutting borders, how you ration MIQ spaces, and also how you prioritise vaccine allocation. All these issues, you can't decide these in the heat of the moment. And I think the government has these really difficult calls that it just wasn't equipped to do. It had no precedence for doing these things. And I think overall they did well, but not perfectly.
People know about citizens' juries? Do you want to just explain what the heck that is?
Oh, this is used a bit for quite complex, nuanced decisions that you basically get a selection of people who are somewhat representative of the public, and then you put them in a room for a day or several days where they're fed the evidence and they have to come up with what they think would be the optimal response. And it's a way of getting for these more nuanced, complex decisions, some idea of what the public actually thinks about them. Does that make sense?
I don't know if that one works. Okay.
Okay, I've got 3 online.
Oh, good. They found their voice online. Great.
So the first is, what were the ramifications of isolation strategies on non-communicable diseases? I would imagine wait lists for surgeries, specialists, GPs, etc. would have been affected significantly, not to mention additional impacts on mental health and isolation. How can we seek to balance this with viral spread if there were future pandemics?
Well, overall, elimination is quite good for healthcare delivery because doctors, for most of the pandemic in New Zealand, carried on and hospitals operated normally. They cancelled all their lists in the first phase of the pandemic, and the hospitals were basically empty. So it was a good time to get your surgery done because there was no one there.
But screening dropped away, didn't it?
It did for a while, and then it returned to normal levels.
Right.
These issues have been analysed. So the pandemic, the effects on healthcare delivery were not bad during that period. It was much tougher during Omicron because the system did start to strain over those big waves of infection.
Yep.
Okay.
Yep.
Another one is from, you mentioned the growing threats from biological weapons and artificial agents. Are there any health lessons you can share with us re the response to such events?
Well, I think again, this depends on the agents and how they're, what we call about their transmission dynamics, how they're behaving in terms of transmission, reproduction number and case fatality risk and so on. But the great thing about elimination is at the border is it stops everything. So it's very versatile, whereas most other things depend on what the agent is. So I do think we've got a huge advantage. But it's interesting to think about, you don't have to be an isolated island surrounded by water because after all, China sustained the longest elimination strategy of any country. I mean, I don't think it was very pleasant for many people, for some people, but it was very successful, even with Omicron. So it is possible, and this is something we've advocated to the World Health Organization, is to have elimination as a default option for severe pandemics. They haven't written that into their policies yet, but we're trying.
Just on those international rules that you mentioned, I think that Ashley Bloomfield has been responsible for sort of updating those with WHO in response to our lessons from COVID. Matt, you got one more?
Are you involved in making the future pandemic plan for New Zealand? If so, how does it look different from the response to COVID-19? If not, what would you like to see included?
Yeah, I am on a group that's meeting for the Ministry of Health to come up with a framework for the next pandemic plan. The Ministry is revising it, and they've got obviously a huge amount of raw material to put into it. So we haven't quite got to the end point of that. I'm sure we'll all hear at some stage, maybe next year when Phase 2 reports. But I'm hoping that it will be much more focused on building elimination as a key strategy.
All right, yep, we'll take a couple of quick questions. Yeah, fellow at the back. No, him.
What's it been like working currently in the context of Aotearoa, where we've been emphasizing things like healthcare funding cuts, increased pushes for privatization, increased lobbying, and so on? And what are some insights you've gained from that you can share with the new generation?
So just to repeat the question, this is about the current environment of cuts to health and what's it like trying to live within that and also think about pandemic responses in the future.
Yeah, at one level I think the reorganised health system is challenging. We actually have got more critical mass at the centre for public health than we did pre-pandemic. We've got a public health agency in the Ministry of Health. I think ESR is going to become a more effective science agency. It's being reorganised. So I think there are some positives. But overall, public health depends on the organised efforts of society, so you need government agencies that are very competent. And I think we have seen some threatened cuts. I'm not sure if they've really happened yet, which I think could make it more difficult in some areas. But I think it's, you know, there's pluses and minuses at the moment.
All right, 2 quick questions and answers here in front. Yep.
It's kind of like Sal's question, but again, kind of to the point of being future health leaders ourselves. Have you got any advice on, you know, how we can best kind of navigate the flip-flopping political climate environments that we see in front of us? You know, obviously with the COVID response, we were under Labour. They seem to have an appetite to close the borders at that point. With the current political climate we're in now, where economic growth is the priority over everything, I could not imagine them shutting the borders down today if we had a pandemic roll in, which would be faced with a national disaster. So what's your advice for us?
Okay,
well,
just
in one
sense.
Well, the easy questions for last. Firstly, the first part of that is actually elimination was very good for the economy. It didn't suffer at all. All of our trade carried on. It was not affected in the least. Obviously, overseas tourism is less than domestic tourism as a contributor. It stopped anyway. Nothing New Zealand, no one was travelling around the world as a tourist anymore. So that didn't alter that. So elimination is not a problem for the economy. And I think most governments would realise actually it's...
Compared to the counterfactual.
Exactly, yeah. So that's good. In terms of how you exercise your voice, one of the key mechanisms, because I think obviously once you're working for large organisations, they don't always appreciate people speaking out, is through unions and representative organisations, Health Coalition Aotearoa, the Public Health Association, the unions that you're in, they can all speak out, and you can get a spokesperson role there, and then you have a protected right to speak out. So that's one way of operating, becoming a spokesperson.
And these organisations are around longer than the politicians are. All right, I think we will leave it there, folks. We're over time. We're going to come back at 11 o'clock. Those of you online, you'll use the same Zoom link to come in. So just a big round of applause. Thanks very much for Michael. Brilliant, mate. That was great. That was really good.
It's good exercise to think about what you say to your younger self.
Yes.
You know.
Righto, folks. Okay. We're going to get underway again. Kia ora, guys. Thanks for coming back. That was a great session with Michael Baker, and we're going to continue with greatness. We've got a session coming up with the panel presentations and discussion, and this is talking about the interface really between clinical medicine, clinical practice and population health practice, from people who kind of walk in those across those two spaces, to show you how they think about it, how they build these into their daily lives. As I said, all of you will end up drifting towards thinking about public health in your career, even if you're orthopaedic surgeons. You'll start seeing once you get all your skill, where you get your skills and your knowledge, and you have competence in dealing with the specialty that you've chosen, you'll start asking questions about why have I got so many fractures coming in that are due to car crashes with drunken drivers or something like that. Who's doing something about it? Or treating the diabetes, or treating the mental health problems, and what are driving these things. So you will end up thinking about it, and this is people who have been thinking about it and practicing it. But there's another interface which we're just going to cover off quickly first, and that is the interface between medicine or health and the planet. And this is another challenge that you'll find in your career, and you'll find that these interfaces are going to be increasingly important, not only as climate change affects health, but there are also all sorts of other interconnections. And a few years ago, we published as the Lancet Commission on Obesity the concept of a global syndemic. A global syndemic. You may not have heard of syndemics, but it's a synergy of epidemics or pandemics that co-occur in time and place and interact negatively with each other. And the global syndemic that we put up was of climate change, obesity and undernutrition, largely a lot of it driven by the food system. That's our biggest challenge going into the future. So there's One Health, there's Planetary Health, there's Global Syndemic, different ways to think about our interaction with the planet. So before we get going, we're going to have a quick presentation from Sarah Hanning. She's from the School of Pharmacy, and she's going to put a proposition to you as people who have just been encouraged to lift your voice, and she's going to talk about what's happening in the school and the faculty around planetary health. Sarah. That's you?
Thank you, yes. So I seem to be missing the pharmacy students. So
the pharmacy
they
students
might arrive.
Join us.
We're going to be two pharmacy students, but never mind.
Okay.
Kia ora koutou. My name's Sarah Hanning, and I'm a senior lecturer and pharmacist from the School of Pharmacy. And I've been given 3 minutes to talk to you about the Planetary Health Report Card, which is a really amazing student-driven initiative that you can get involved in if you're interested. So in pharmacy, I guess 2 years ago, we kind of recognised that maybe we're not doing as well as we could or should around integrating planetary health concepts into our already quite packed curriculum. But with the changing climate, obviously this is going to become more important, and as future health professionals, you will all be working in a very different environment to what we have at the moment. So the Planetary Health Report Card is a metric-based and student-driven initiative. The idea is that it helps to facilitate and inspire planetary health and sustainable healthcare educations and health professional training programs around the world. So it has 5 different sections relating from your specific curriculum, so planetary health curriculum, right through to research and more broader sort of campus-level initiatives that link to sustainability. So the School of Pharmacy has taken part in this for 2 years now, and we've seen changes in our program as a result. Last year, nursing joined for the first time, and in this upcoming year, we really are hoping that we can get a medical team as well. So there's a QR code if anybody, as I'm talking, is interested in signing up. There's a form there. Associate Professor Andrew McCormack and Dr. David Menkes have offered to be the faculty mentors for medicine. So if you're not sure and you want to think about it, you can also email Andrew at any time too. So I suppose the thing that makes it difficult to recruit people is that it's a Northern Hemisphere driven initiative, and so the work is done over our summer period. However, it's quite flexible, and the templates usually come out in October of each year, and then you've got until about February. So there's quite a long period, and you can fit that in as needed. You work in a team, and you answer a series of questions. I have an example of a question up there. So the very specific question: does your medical school curriculum address the relationship between extreme heat, health risks, and climate change? If it doesn't, then it gets 0 points. If it's in an elective course, then it gets 1 point through up to 3 points. So you assign a score, and then you give an explanation. So there needs to be some kind of supporting documentation for any point that you give, and it all gets peer reviewed internationally, and then you get a score at the end. So if you're interested in taking part, please, we're recruiting now, but you don't have to do anything until October, so even if you're not sure, we'd really love it if we could get medicine involved this year. In terms of what you get out of it as students doing it, so you get a published report with your name on it at the end, so that's good for your CV if that's what drives you. Also, though, you're integrating, helping to drive change, and in the pharmacy program, I know that some of the recommendations that come through have been implemented and have resulted in, for example, throughout our whole program now, when anybody talks about drug delivery systems, they also talk about the environmental impact of those. So that's one really tangible change that we've made in pharmacy, and I'm sure there are many that could be made in medicine as well. So thank you for your time, and I'll leave it there, I think. Cheers. Thank you.
All right, excellent. Thanks very much for that. Zap onto that if you haven't already. Welcome, Sue. All right. Now we're going to hear from these clinicians / public health people. We're going to hear first of all from Dr. Aumua Herman, and we're going to then hear from Professor Sue Wells. Thank you very much, Sue, for stepping in at the last minute and scrambling across to get here. Appreciate that. And Dr. Nina Sue, who's coming over from emergency room. She wasn't sure whether she'd be on duty today to come and talk to us, but she is on duty and she's been released, so she's heading over now. So she'll be here a little bit later. So we'll hear from them and collect your questions, and we will have a great question and answer at the time. Good to see that the people in the regions have worked out how to put their questions in. We're expecting some good questions from you. All right, can I ask Lachlan Markinova? Where are you, Lachlan? Hemmed in up there, right at the back. Okay, come and introduce Dr. Herman.
Kia ora, everyone. I have the privilege of introducing and inviting up our next speaker, who's had a colourful and busy career both as a clinician but also in public health. Starting her training in medicine, she moved into public health and epidemiology, completing her PhD at this university here in Auckland. After holding various roles in public health, most notably in 2018, she became the Secretary of Health for the Cook Islands, and led arguably one of, if not the most successful COVID-19 response. Not just getting rid of COVID, but keeping it off the shores entirely, which is very commendable. She's now back in Aotearoa working at the Waitemata DHB in her role as the Pacific Health Director, and really has dedicated her career to equity. So please give a warm welcome to Dr. Aumua Herman.
Just go to Kia ora ana, kia ora to everyone here. Excuse me. beginning, gosh. It's such a privilege to be here today, and for the short period of time I have to speak to all of you, I'm hoping that we can at least give you some insight into potential career paths for you into the future. So in the introduction, thank you, Lachlan, I thought it would be important to sort of give you some insight into the Pacific Island countries and territories that are here highlighted with their flags. Many of us are working in New Zealand, studying in New Zealand, but not necessarily aware of where we are in terms of the Pacific Ocean. And there's about 22 countries and territories, because some belong to New Zealand, the realm of New Zealand, that's Tokelau. And as you know, the realm of New Zealand countries in the Pacific are the Cook Islands, Niue and Tokelau. And you've got French territories, you've got US territories, so very interesting dynamics in the region. And the other thing about this is that there's about 15 million people living, and you have to exclude New Zealand because New Zealand is part of the Pacific as well, and Hawaii. But about 15 million, and most of them are living in Papua New Guinea, just around 11 million. So you can sort of see where the population groupings are, and on top of that, at least 91% are low middle income countries. So countries that are poorly resourced to deliver health services for their populations. Now, in New Zealand, it's important also to acknowledge the migration, the historical linkages from many years ago, where many of our Polynesians, which are really the countries of the Cook Islands, Samoa, Tonga, Tokelau, Niue, migrated to New Zealand, and prior to that were the indigenous Maori population of New Zealand. And the thing about that now is that when you're looking after Pacific peoples, it's really important to understand some of this history, noting that 90% of our population, Pacific population in this country, are Polynesian. So for me, I was born in the Cook Islands, and we were at a point where tertiary education was not available in the Cook Islands at the time. That sort of gives you an idea about how old I might be. And so I did medicine. I studied medicine in Fiji, and then we had the first coup. And so I completed medical training in Papua New Guinea. So having medical training in these countries gives you some idea about the challenges populations face and the health systems that look after them. All my postgraduate studies training happened in New Zealand. We're New Zealand citizens, Cook Islands, Niue, Tokelau as part of the realm. And of course, you're at that point in your life, or you might have already decided, which specialty am I going to choose? When I was a medical student, I was definitely going to study general medicine. That was my specialty of choice. I loved medicine, but I went back to the Cook Islands after graduating. I was a female doctor, the second for the Cook Islands, in fact, and we need a doctor for our women. And so you can see how this goes. Back in the day, you listened to your older colleagues, and so I went to ONG. Now, the thing about ONG is that you do medicine, you do surgery, and I thought, okay, best of both worlds, let's do this. And so I came to New Zealand to do a diploma. But during this short period of my career, I realized that the importance of prevention was probably something that really resonated with me. Teenage pregnancies, I'm sure we can do something better in terms of helping young women, in terms of reducing those rates, and also the importance of quality, making sure our indicators were appropriate, data was collected, and in those days we were still on paper, and of course moving it to Excel spreadsheets. And so thinking about that and the importance of prevention, I thought about public health. And this was the beginning of my journey in public health. Started with a master's here in New Zealand and then went on to do my fellowship. At the time, it was the Australasian Faculty of Public Health Medicine that was the only one available, and later on, we currently have the New Zealand College of Public Health Medicine, which both operate in New Zealand. And of course, after that was the PhD. Now, what was interesting about the PhD, and I must say I really enjoyed this experience, was that I wasn't really interested in injuries, and least of all, road traffic injuries. But in the Pacific, we knew that this was a significant but poorly quantified burden. In the Cook Islands, those of you that have visited or have heard of, we drive motorcycles with no helmets, and we drive fast, especially our younger people. And we had a really high rates of motor vehicle crashes, injuries that ended up in New Zealand for care, or mortalities. And this became an important part of my research career and looking at this. And in Fiji in particular, where the population is much bigger than the Cook Islands and other populations, we did a study, case control study on driver sleepiness. And of course, we were able to demonstrate, as we have in other parts of the world, the role of driver sleepiness in road traffic injuries in the Pacific. Now, you know, I thought, okay, I've done enough now. Let's just focus and hunker down and build my research career, carry on doing public health. And then I realized that I missed the clinical aspects of medicine. I didn't want to go back into the hospital to work. And I thought, you know, some of us, we just love our weekends, we love our public holidays, no long days, no long nights. And I thought, I'll do general practice. And so that's where I ended in terms of my career path. And I do some GP work wherever I can, whenever I can, because my life is a bit busy at the moment. But I wanted to draw attention to some of the places that I've worked. In time, this is possibly going to be your career path, where you may choose to, or you may be provided opportunities or seek out opportunities to work in a range of settings. So way back in the years after I had attained my public health fellowship, I returned to the Cook Islands to work as a director of public health. At the time, as we know in the region, sometimes you don't always have capacity in country. I ended up having to cover the clinical director role as well. And it was an important experience to sort of start getting introduced to the rest of the global public health community, and also in the Pacific region. Then I had an opportunity to become a medical advisor in the Australian, our equivalent Ministry of Health, in the Office of Aboriginal and Torres Strait Islander Health. And it was an interesting experience providing medical advice, public health advice with, I think, 3 other public health fellows. And the thing about this, and I suppose something to understand in terms of resources, and we'll talk about it soon, is that in the Cook Islands, I was working in an environment with poor access to resources. You go to Australia and you just have lots and lots of resources to work with, and that includes finances. Eventually, I returned to Auckland and was a medical officer of health in the Auckland Regional Public Health Service. And at the time, we had the mumps outbreak in Auckland, and I was the portfolio lead for measles, mumps, rubella. And it was an interesting time as well, understanding the immunization rates and the vulnerable populations, which were mostly Pacific and Maori. And even in Pacific, it's really important to understand the nuances, with Samoan being half of the population of Pacific peoples in this country, and they were the ones that were most likely affected. So interesting times, but learning how to work with your colleagues around outbreaks and providing clinical advice. An interesting part about this work as well was that we realized that the MMR vaccination coverage rates were not at the level we needed them to be, i.e. above at least 90%. To prevent an epidemic, and we were worried about measles, and sure enough, not long after we had a measles outbreak. And then, of course, I've done general practice work. Now, the other part of my work was working as the Director General in the Cook Islands Ministry of Health. The opportunity sort of came before me, and at that time in my career, I thought, if there's anything I can do well, it would be to return to the Cook Islands and serve. And I know all of us here, that has really been probably one of the important reasons for you choosing this career path. It's about service, not necessarily about the money. I think if you were chasing money, you'd choose another career. But anyway, we're here today. But when I went in, and I was thinking, I'd just come out of Australia, and New Zealand as well. And every time I shifted careers, it was like everyone wants to do health reforms. And I thought, oh my goodness, here I am. So we were going through health reforms in the Cook Islands, and it's a very difficult and tricky environment to work in. But when you're the lead of the organization, you have many opportunities to determine how that plays out. And also with the training you have, the opportunity to alleviate anxiety and mitigate risks to the system, to the government, and also to the population. But one of the big things we did in the health reforms in the Cook Islands was to flatten the structure, the organization structure, make the decision-making process more efficient. And when you're a clinician, you have that knowledge in the background. When you have public health training, you have the population health skill set to help make those decisions. And I had a little bit of research training as well. And so it wasn't, it was a difficult time, very heavy work, but I think we did quite well in that time period, but it wasn't that straightforward. And I suppose we're going through health reforms now. Many of our workforce, health and managerial people are now facing that process in this country. That was 2018. And we were just preparing the system. End of 2019, COVID arrives. And sometimes you look back and you reflect and you think, my goodness, was this the time that I needed to be in the Cook Islands? We prepared that system, and the timing was just appropriate for the arrival of COVID-19. At the time, we were setting up our public health systems, clinical systems, rearranging our health services so that we were pushing resources closer to the people. We were standing up community clinics in the community settings. So it was really an important time. And it's great to have Professor Baker here. Sitting in the Cook Islands, you can be quite isolated. We, at the time, had some conversations with our Director of Public Health in New Zealand, who were colleagues of mine as well as Sir Ashley, who was running the system here. But I think one of the things that we did, yes, we did shut our borders, but and we had to do that out of necessity, but the economic impact, because tourism, for example, in the Cook Islands is one of the important economic drivers for the Cooks, paid a huge price. But we had no choice. Well, no one was traveling as well. But what it did, though, for us was return the Cook Islands to what it used to be in the day before. And if you speak to many of our community leaders in that time, that was probably one of the first times the Cook Islands was able to enjoy the island to themselves. And because we shut the borders, we were doing everything. We didn't have to wear masks, but behind the scenes, the health system was preparing. We were doing the quarantine processes similar to New Zealand. And I must say, you know, one of the things we don't always appreciate is that New Zealand protected the Pacific because of New Zealand's strong border control measures, and we don't often acknowledge that. So the other thing about this is that policy can take time. When I was in the Cook Islands in 2018, we decided that we were going to aim for the tobacco-free Pacific, which is this year. And we decided that we were going to focus on a few islands, take them smoke-free, and the definition of tobacco-free is less than 5% of the population smoking. We were not far from that, and then COVID came. We always blame COVID. And of course, our whole work program was diverted to protect the country, prepare the country in case we had COVID arrive. By the way, we have no ICU services. We have limited HDU. We were frightened, and so were other Pacific Island countries. So that was back in 2019. Only this year, those islands that we targeted to be smoke-free, just last week, in fact, the Cook Islands celebrated four of the islands to go tobacco-free, so no sales of cigarettes in the shops. Now, we're talking about small populations, maybe 1,500, but they made a big deal. WHO was happy. And I think that's the thing about it, just seeding all of these good policy moves. There's always that stuff behind, not perfect, haven't achieved the actual less than 5%, but at least we've stopped smoking in these particular islands that are vulnerable. And I think the other thing about the regional work, you've got World Health Organization operating in the region, the Western Pacific region we call. The regional director is a Pacific colleague of ours. He trained in the region. He's Tongan. And many of our Pacific colleagues know him well. And so that has been a really important shift in leadership in the region. New Zealand, Australia were completely supportive of having a Pacific Regional Director for the Wipro region. The Secretariat of the Pacific Community or SPC is the usual public health policy arm in the region. Some of you might have heard of them. Then MFAT is our Foreign Affairs and Trade. DFAT is Australia's. You've got UNICEF, ADB. A whole lot of partners are working in the region. One of the things we've always talked about in working in the Pacific is the ability for us to maneuver, because every agency has their own agenda and trying to make sure that it's always for the Pacific population. The other thing that we started off in 2019 was the Polynesian Health Dialogue. So all of this good work was being put in place, and now you will see in the Ministry of Health with Global Health, you have the Polynesian Corridors program that has been funded to support the Polynesian countries. So you've got your realm countries, and then you've got Tuvalu as well. And Samoa and Tonga. So some fantastic things that have happened in recent years in New Zealand as well as for the region. I returned and in 2021 was the Director of Pacific Health at the DHB. This was an important time to understand how Pacific policy could operate at the district level. One of the things is that we have these community health providers or community health navigators who help our patients or Pacific patients navigate our health system. It was an important time as well, but I suppose one of the important lessons I actually got to be part of was when we were setting up the clinical governance for the COVID-19 vaccination program. This was the NRHCC, Northern Region Health Coordinating Centre for Northland as well as Auckland. One of the things about this vaccination program, we were working in spaces where we didn't necessarily understand everything. What we did know, though, was that we needed to make sure our adverse events register was operating. We wanted to make sure that we had good clinical governance, and that was my role to help establish that and set up appropriate representation to guide how the NRHCC would deliver the program in Auckland. Currently, since the beginning of last year, I am sitting in the Ministry of Health as the advisor for Pacific Health. It's an interesting time to be here. We have lots and lots of work to be done, and we'll see how we go. Why population health? Health systems are expensive, we all know this, and as in your role as future leaders of our health systems, I don't think you'll have a choice. You will come to understand this as your career grows. But clinical leadership and governance is critical for any health system. I learned this very quickly in the region with those countries that had DGs with no clinical experience, because it's a bit more difficult to understand the clinical nuances and apply that to management, to policy and practice. Human resources, no workforce means no health system, and appreciating and acknowledging the workforce we have, and not just medical, nursing and allied health. We don't do too well with allied health, and I think there's more emphasis on that now in terms of making sure the speech language therapist is available for us when we have someone with a stroke, for example. So I think appreciating the physios, the pharmacists is so important. And I'm almost running out of time. You need money. Whether you have lots of money is a different story, though. Countries, sometimes we need to remain grateful for what we have, in my view. In countries such as the Pacific, we have much, much less resources to work with. In New Zealand, we are not too bad. We make a lot of good use of our money here. Australia, of course, has a lot more to work with. And I suppose the New Zealand health reforms have shown us the importance of having better access and equity so that we look after our vulnerable populations, Māori, Pacific, young, older folk, and our disabled communities. So outside the health system, you've got determinants. Don't forget when you're seeing your patients, do they have warm housing? Do they have money to buy food, healthy food? The commercial determinants, these are huge players in the field. You will know from Professor Boyd, his challenges, his advocacy against poor food or big food, big pharma, big tobacco, and so forth. And of course, don't forget the global environment we live in, when some countries influence the trade or put in place tariffs that are likely to impact us because we are all connected. The price of oil, war everywhere. And then, of course, we cannot forget, as we are working through our medical degrees, the importance and the impact of climate change, climate crisis, pandemics, and the threats of antimicrobial resistance. We are one of the most likely to prescribe antimicrobials. AI, or the misuse of it with designer pathogens potentially. Then, of course, nuclear environment toxins, microplastics, they're in human tissue now. And of course, some countries are struggling to feed their populations. Some have poor access to clean, fresh water, and the obesogenic environment we live in. So I think my closing remarks really center on your career shifts. There's a good chance you're going to have multiple careers, perhaps, and so remain flexible and pay attention to what's happening in AI, evolving systems in health across the society. Clinical population health are important areas for you, and I think it's possible. You might be a clinician or cardiologist in the hospital, but you'll be doing research to see how you can improve the health outcomes of your patients. And the other thing about your important role in policy and leadership in health systems, your clinical experience is going to be critical to help inform health policy. You will know the most important parts that matter to your patient and to the families that you look after, and that will be critical for health policy. Don't forget the global, regional, and national opportunities. And finally, just your clinical skills. Do well, hold them well. They're going to carry you throughout your life. I was going to add life skills because you grow a lot of life skills as you're training through medicine. Your research, you need the evidence, and that would be important for you in the academic space. Your networks, these are your peers right here today, and they will be your peers in the future. And then you'll make newer networks wherever you are, and they won't be limited to national. They'll go further beyond and look after you, because that's so important in terms of making sure you get through life. Thank you very much. Kia ora ana, kia manua.
Kia ora ana, thank you. All right, we'll take questions for Amea at the end. All right, now I'm going to ask Alicia Boys. Thank you very much for stepping in, Alicia, as well, to introduce Professor Sue Wells, who's also stepping in at the last minute. So stepping in the slot. Yeah, thank you.
Kia ora koutou. So I'm stepping in for Nikita today. Hey Nikita out there. So good morning everybody. It's a privilege to introduce our next speaker, an individual whose work has profoundly impacts health outcomes and inspires many. We're delighted to welcome Associate Professor Sue Wells from the Head of Department for General Practice and Primary Healthcare. Sue is a distinguished figure renowned for her innovative approaches and significant contributions to public health and clinical epidemiology. With a background as a GP and a public health specialist, she has consistently demonstrated a remarkable ability to transform complex health challenges into groundbreaking solutions. Among her many impactful achievements, Sue leads the New Zealand Predict cohort study, which has generated new national cardiovascular disease risk equations, and she co-developed the Your Heart Forecast Risk Communication Tool. She's also the co-director of the Significant Vascular Risk Equity for Aotearoa New Zealand program, which leverages national data sets to address critical issues of equity in vascular health, particularly for Māori and other high-risk populations. Her leadership in large primary care cohort studies, such as the 2014 ProCare Adult Cohort Study, aims to identify the true burden of long-term conditions and inform public policy to reduce health inequities. Her commitment to improving health outcomes and fostering collaborative environments is truly commendable. We're incredibly excited to hear her insights today, so please join me in giving her a very warm fifth-year welcome to Associate Professor Sue Wells.
Oh, thank you so much, Alicia, for that lovely introduction. Tēnā koutou, kua hui hui mai nei. E mihi ana ki ngā mana whenua, e mihi ana mātua me whaia, ko Sue Wells toko wengawa, nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So, thank you so much, Alicia. 10 years in general practice, retrained public health medicine, actually did a very similar sort of academic route to with Ormea. I did a diploma of obstetrics, went into general practice, did my fellowship in general practice, then public health medicine, masters in public health, PhD, College of General Public Health Medicine. So I thought, gosh, I did the same as you, but backwards. So I'm currently Head of Department of General Practice and Primary Healthcare here, but for 6 years I was Associate Clinical Director of ProCare Primary Health Organisation from 2016 to 2022, so right in the middle of COVID as well. Now there are about 30 PHOs in New Zealand, and 96% of New Zealanders are enrolled in a general practice. And what happens with funding, the government provides funding to PHOs for primary care services, and then this gets distributed to their member practices. So I said to Boyd I could talk about population health from a PHO or a GP perspective. ProCare at the time had 170 member practices with 800,000 enrolled people that made up just under half of the Auckland region, and just under a third were considered high needs, Māori Pacific, or living in the most deprived communities in the Auckland region. So population health from a PHO or a practice point of view is concerned with the distribution of health and health outcomes for the enrolled population, and also the distribution of gaps in care, gaps in access to care, processes of care, and health outcomes. And PHOs are really, and practices, very data rich. In 2018, the PHO board asked a group of us at ProCare to put together a population health report based on a whole series of data. And I'm just going to give you a little flavour of what that report showed. And so this is a bit, busy, but I'm going to walk you through it. We're talking here about ASH, which is ambulatory sensitive hospitalisations. These are potentially avoidable hospitalisations should everything in the community, both health services and socioeconomic determinants of health, be ideal. So potentially avoidable. The column of categories are ASH categories, and then with all the columns down the blue is Māori, Pacific, Indian, Chinese, European and other. This is for our babies in ProCare in 2018, 0 to 4. It's a heat map, so the greater the brighter the blue, the bigger the blue, the more ASH hospitalisations. And so for 0 to 4, the biggest contributor to ASH rates is respiratory conditions for Pacific, followed by Māori infants. Now that you've got your eye on for our babies, for 5 to 14 years, it's dental conditions, dental decay resulting for extraction for Māori children in particular, then Pacific and then Chinese. For youth, it's cellulitis, particularly for Pacific youth. 25 to 44 years, cellulitis rates have come up from the younger adolescents, but very, very worrying for ProCare at the time was a flag for angina and chest pain, particularly for Pacific and Māori young adults. 45 to 64, cardiovascular ASH has tripled, and I've got the arrow there, with Māori, Pacific and now Indian at the same ASH rates, around about 17.2 per thousand. 65 to 74, increasing ASH rates for cardiovascular disease and increasingly heart failure, and for Māori, admissions for chronic obstructive pulmonary disease, of which smoking is a big risk factor. So having seen this report and many other data about access to care and processes of care, the ProCare board said we need to do something about this. We cannot carry on. Once you see the data, you cannot go back. So they asked for a population health strategy across a life course to be totality-based, to be equity-focused, and really understand the socioeconomic determinants of health. So you've seen this before. Healthcare can only contribute around about 20% to health. 80% is health behaviours, the physical environment, and socioeconomic factors, education, income, job status. So what we did was we worked with our entire clinical community, allied health professionals, as well as GPs and nurses. We worked with iwi, and we worked with urban Māori, iwi providers, and Pacific, Asian and refugee communities, and asked them, with this data and with their perspectives, what would be the 5 health goals that we should target. And it came out to be our babies, 0 to 4, youth, well-being, which mean mental health as well as preventive care, long-term conditions, and the quality of life for older people. So putting your population health hat on, we needed to know what interventions should we be implementing in ProCare, and we needed to know what's the evidence for effectiveness. Would it impact on Māori health gain, and would it be equitable? We also used the dimensions of the Ottawa Charter to work to implement interventions that were not only with the clinician and the patient and their whānau, that clinical interface, but working alongside that clinical interface and upstream, what other interventions can we put into place that will make a difference? So I'm just going to give you a few examples. Develop personal skills. We worked very much with Health Navigator. It's become Healthify, on high quality consumer information, multimedia, multi-languages, and having that integrated into general practice. Strengthening community action. What's an example? We've long worked with Pacific Churches, the Healthy Village Action Zone. So we, in particular, started to talk to them about how we can reduce cellulitis for youth. Creative supportive environments. This was actually linking all the practices to Kāinga Ora, Housing New Zealand. Reorientating health services. An example of this might be vaccination clinics at Marae. We're working with Ngāti Whātua Orake to have cardiovascular risk assessment happening in their gyms. Another one might be Hapu Mama smoking cessation services. And lastly, healthy public policy. We made a huge amount of submissions to the council in particular to reduce the alcohol outlets in South Auckland. South Auckland has the highest density of alcohol outlets in New Zealand. So when we're thinking about personal health care and you're treating the patient and their whānau when they come to present with a problem, but I see that personal health is so nested within population health, where you need to be able to systematically treat all appropriate patients while working to change that environment, making it easier to improve health and well-being. And all of those partnerships were so important. This is my old practice. It's Whakaari Medical Centre in Mount Albert, and I'm just going to show you two interventions that happened in general practice at the time. So the first one was after we did the population health report for all of ProCare, we did population health reports for each practice, so and had a dashboard so practices could look at their own data. So this is a practice. When we gave this is who you care for, the number of people you care for, by ethnicity and by deprivation. Here's the indicators for the babies, the children. We had for youth, this is for well-being, smoking and alcohol, indicators, cardiovascular disease and diabetes, and for older people, and you can see polypharmacy, flu vaccine, falls assessment. So things really important to improve for across the life course. Every year then we ask practices to do an equity gap analysis, and I'm sorry it's really small, but for a set of clinical indicators, this is one practice screenshot, a set of indicators to see if there's an equity gap. And for them, they were doing really well with immunisations, and they said, keep up the good work. Yeah, you were doing well. But there were gaps. in cardiovascular disease, primary prevention, and for diabetes. And so it gave them an opportunity to reflect on what was happening for their own patients. This is the last intervention I wanted to show you, is about collaboratives. And this is where groups of practices work together on a topic. We had 7 health topics right across the 5 health goals. And this was in 2020, just when COVID came. So we had PPE and the whole 9 yards, but actually 80 practices participated, just under half of the whole network. And I'm going to show you one of the 7 topics, and this was microalbuminuria. So for the management of people with diabetes who are leaking protein, micro or macroalbuminuria, they should be treated with an ACE or an ARB to protect their kidneys. So as a storyboard, and this is an example storyboard for the practices, we asked them to look at their present situation, look at their data. What's the present situation? Who are they managing to treat according to ACE and ARBs, total for Māori, for Pacific, and for those who lived in the most deprived quintiles. We then asked them to put in an aim. How much do they want to improve in the next 5 months? They then needed to sort out what kind of changes they're going to put in place and then monitor their outcomes. And here's the tracking reports that they would go to. This is one practice. They had 19 people who weren't on an ACE or an ARB, and they could click on this 19 and find the people and then follow them up. This is the results of that particular collaborative. The black line is the rest of the network, and the green line is the collaborative practices. So you can see that they started off pretty much the same, 75%, 78% were being treated, but by the end, they far outstripped the rest of the network. And very importantly, it was as good for Māori and for Pacific. So I guess for me, the summary is clinical care is looking after individuals and their whānau, but population health is about achieving equity and social justice for the population that you care for. And it's systematically treating all the appropriate people. It's about partnerships with whānau, with community and social services. And I guess what I'd like to say is population health is everyone's business. So thank you very much.
Thank you, Sue. Gosh, what an amazing demonstration of use of data to drive clinical practice through a population lens. Oh, that's yours, right. I don't think you've got slides, have you, Nina? No. Okay, so thank you. Nina's, you can tell by her scrubs, she's come straight out of ED. So thank you very much for giving us your time. And Malika Brownlee-Armstrong is going to come on down, is going to introduce you, Nina.
Tēnā koutou katoa. It is my pleasure to introduce our next speaker, Dr. Nina Sue, who graduated from this university in 2017 and is currently a training registrar in paediatric and emergency medicine. Dr. Sue is passionate about addressing the root causes of health inequities, particularly those affecting vulnerable communities. Frustrated by healthcare systems that felt like a revolving door, she founded the podcast Revolving Door Syndrome, which explores the interconnectedness of healthcare, education, and justice, and analyzes equity and systemic issues. In the 2023 general election, Dr. Sue stood as a candidate for the Opportunities Party in the Epsom electorate. Her campaign emphasised the need to tackle the social determinants of health with a cross-party cooperation approach and had policies aiming to get people out of poverty traps and improve the health of Aotearoa New Zealand. Throughout her career, Dr. Sue's work has highlighted her drive to create true systemic change. Her dedication to equity and her innovative perspectives make her an incredibly valuable speaker to have at our Population Health Intensive. So please join me in offering a very warm welcome to Dr. Nina Sue.
Thanks everybody. That was a very generous introduction. So kia ora tātou, ko Nina Tokawengawa. Welcome everybody. I'm Nina. So if you can bear with me, I only wrote this speech last night. I have no slides and I have no formal public health training anyway. So what I say might be a little bit out the gate. So if you could put your phones away, put your laptops down. I know, it's a bit hard these days, but I'm sure you could give me 5 minutes of your attention, please. So here I'm a paediatric emergency advanced trainee. I also host the podcast Revolving Door Syndrome, which is in a little bit of a hiatus at the moment, and I ran in the election of 2023 for the Opportunities Party. So I did all these extracurricular activities, probably because I've undiagnosed ADHD, but I always saw how much of the interplay there was between the socioeconomic determinants of health and what was coming through the door in the emergency department for the kids. At the moment, I'm actually working in the Starship ICU, which seems very distant from population health, but actually it's somewhere where you see pretty clearly how poverty, lack of access to health and education actually has on children's health. But that's actually not the whole story. Because I think something's actually going very wrong in healthcare, especially in the Western world and how we look at healthcare provision. It's pretty clear that whatever we're doing right now is failing. We're seeing that people are on average living longer, but people actually don't seem to be living better. Modern scientific research has given us novel therapeutics, new medical technology, which is allowing us to do more. But are we actually healing people? Because this is what I came in to do the job, right? I think there's actually a very significant separation between what we can actually achieve at the patient bedside and the public health factors that are actually causing much more impact on our patient outcomes. At a population level, the gains of much of our latest scientific achievements are amounting to an improvement of rounding errors. More focus is on the next generation of antihypertensives or anti-diabetic pharmaceuticals, but we're not really getting much focus on actually the lifestyle factors that could reverse metabolic syndrome. And it's been said before that the healthcare system is a black hole. You could put more and more and more money into it and you're just not going to see any change. The more I work in health, the more I see that actually this is the case. The more, the interventions that would actually improve health outcomes cannot be done by the healthcare system itself. If we just have more doctors, more nurses, more allied healthcare and a bigger FIMAC budget, it's just not going to fix the problem. You can't use those to fix the consequences of poor housing, poor income, a bad environment, poor education, and individual lifestyle choices. We can't keep expecting the healthcare system to fix these issues that are caused by factors that are far more upstream than how healthcare is provided. And one of the biggest issues facing health is actually social media, the use of AI, and the lack of trust in our institutions. As a millennial, I am 30, I grew up in the internet age. We thought that having more access to the internet was going to make people smarter, but actually I don't think that that's the case. And the problem with social media is that we are no longer living in a society of shared reality. Anyone who is on social media has experienced what it's like to be taken down a rabbit hole. 1 minute you're watching reels about cooking healthy meals. The next minute you're watching reels about extreme diet, like an all carnivore diet or all fruit diet. And for anyone who's against banning social media for young people or who are against encouraging reducing social media, they need to realise that these algorithms are working to push people further apart into more and more extreme views. The longer people spend online, the harder it is for them to understand what is real, what is false, and people becoming far less tolerant of people with differing opinions. But what I'm not advocating for is everyone agreeing about everything. I mean, we're here to learn science, right, as part of medicine. The point of science is actually to explore new ideas and debate. Every piece of evidence, new or old, needs to be able to be picked apart so it can stand on its own legs. Increasingly, it's becoming harder for academics and clinicians to openly talk about the issues that are facing our patients today. Many no longer feel comfortable voicing their thoughts and opinions for fear of being labelled something abhorrent. It is precisely because of this lack of ability to question or debate ideas that is causing falling trust in our institutions. One of the most effective public health interventions we have ever had is widespread vaccinations. Now, before COVID-19, the impact of online misinformation was already causing vaccination hesitancy. This hesitancy might be worse due to the perceived lack of transparency on where COVID-19 came from, the effectiveness of the vaccine, and the benefit of high-level lockdowns. I'm now seeing more children in ICU or ED of middle-class, educated families choosing not to vaccinate their children. I even had a family who refused vitamin K for their newborn baby, resulting in spontaneous intracranial bleed. To tackle these issues, it's actually not enough to spread the word through awareness campaigns or just having a good conversation between your GP and a patient. We have to look at why people have lost trust in our institutions. We have to ask if the institutions are deserving of this trust. Research here done at the University of Auckland by Dr. Alison Avenel, Associate Professors Mark Boland and Andrew Gray have uncovered multiple examples of fraudulent clinical trials published in peer-reviewed research journals. They've also done research showing that studies that cite studies later found to be fraudulent are not updating their citations even when their citations are found to be fraudulent. On my podcast, I also spoke with Professor Julia Ruckledge from the University of Canterbury around her research into nutrition and mental health. She had robust clinical trials on the benefits of nutritional supplements and mental health, but she couldn't get it published because editors were worried that if they published it, it would affect people's perception about the medical model of mental health and SSRIs, and worried that it would encourage people to stop taking SSRIs. But the whole point of science is to allow new evidence to come along and challenge the old. I also spoke with Dr. Peter Boghossian, philosopher and academic from the USA, who orchestrated the grievance studies affair. He and two other academics wanted to prove that the peer review system enabled poor scholarship and did not have the level of scrutiny required to uphold high research standards. They were able to publish 4 completely bogus papers in various social science journals before they were caught. If our whole foundation of medicine is supposed to be evidence-based, then this whole house of cards will fall over if our research systems are not robust enough to properly examine what is true from false. This goes for anything from public health interventions like vaccination and water fluoridation, all the way to new age immunotherapies, anti-diabetic medicines, or transgender health. If we cannot make sure that the science is sciencing, then we don't deserve people's trust. The whole point of your coming to university is to learn from your professors, learn from each other, and learn from doctors like myself who come here to speak to you. But I implore you to be skeptical. Skeptical of your professors, skeptical of each other, even skeptical of me. Especially be skeptical of people who claim to have all the answers. Because I can tell you right now, no one has all the answers. And the more we become comfortable with disagreement, the closer we can get to finding better solutions and become closer to finding the truth. And so with that, I'm really excited to get into this Q&A.
Our
Mayor, come up and do that. Yes, that works. Righto, grab a seat, share that between you. I'll give this one to... No questions here? Righto, folks, how do I do lights on here? I don't know, lights. No? Anyway, we've got the lights as they are. Righto, thanks for that, you three wonderful women, for coming and sharing your stories with us. Quite a lot of common threads running through that, but with very different emphasis. Right, we're going to take questions online from people in the regions and from the room as you practice what Michael Baker has implored you and others have implored you about speaking up and showing your voice. What's been running through your head, and what do you want to ask these clinicians come public health physicians? Anything online? Oh, sorry, yes. Let's go, Baker. Okay, let me just repeat the question of people online. So it's a question about how do we get to this sort of deal with the anti-vax hesitancy without blaming individuals, and your opinions on that. Okay, who's going to have first crack at that? All right. Oh, Matt. No.
Oh, I don't know. Oh, I don't have any solutions. I've only got problems. I think it's part of the wider problem of trust, like I was saying, is that I think we do have to grapple with the consequences of the COVID-19 lockdown and the whole COVID-19 pandemic period. I think there are a lot of people who raised concerns, and I think anyone should be able to raise concerns, and I think a lot of people felt like if you questioned it, then if you just questioned the COVID-19 vaccine by itself, you were immediately labelled anti-vaxxer, which is not true. I think people should be, they should be allowed to question whether they should have a COVID-19 vaccine or whether it's safe or not. So I think as a long-term strategy, I think we have to have, as healthcare professionals and the wider community, we need to have a little bit more humility and understanding about why people have their hesitancy around things like the COVID-19 vaccine or other vaccines in general, really. I think it's really hard because you're not going to be able to get to the bottom of it in like a 10-minute GP conversation. So I don't have any answers, but I think people need to be given the space to have a longer conversation to actually talk about what are their real concerns around the vaccine and whether you can address it. Because for some families, for example, we've had quite a few babies come through with pertussis through the ICU, and they get really, really sick. And I think it's unfortunate, but at that point, the families sort of think, oh, I should probably get my child vaccinated and all my other children vaccinated. So I'd like to hope that people can get their kids vaccinated before that happens.
Mad, you wanted to comment on that? Did you have to deal with that in the Cooks?
Kia ora ana. I really think that we might have lost touch with the people that we serve. We've taken control of the health system. We are the only ones that know best, and we've forgotten about our people, our community. And you'll find that in countries where the community leaders in particular have a lot to say about how the health system is run, then you have better trust, better relationships. I saw this in the Cook Islands, and I must be careful in how I choose my response. Remember, when you work for government, you stay diplomatic. One of the big things for us was trying to find a way for the community to help us build the response to COVID should it arrive. the first things we did as a ministry was to call in all the community leaders in the Cook Islands. We had them in one room, we told them, we listened to the questions, and it was unanimous, very clear. We will keep the borders closed, even though we had businesses putting pressure on the country to open. So our Prime Minister was in a very difficult position at the time. You know, do you listen to the people who vote you in, or do you listen to the business people that really needed to make money? So I do think we need to question ourselves. Who do you know in the community? And as clinicians, as health professionals, we need to remain connected to our community leaders, whoever they are. We'll have different links and keep those links live. Thank you.
So, do you want to say something?
Just one thing. In the practices with anti-vax conversations, or it was actually much more a matter of just listening to people's concerns, and that two-way conversation. We don't have as much conversation as we need to. Very often people were hesitant, were worried, were concerned, didn't want their babies to be immunised, but it was actually the 10-minute conversation. You can have a lot in 10 minutes. I don't believe that. I was thinking, really? No.
More than that?
You don't need more than that. No. You just need to listen. It's about relationships, and it's about the trust that you have with ongoing long-term relationships. And that's actually one of the joys of general practice.
And on the canvas, there are some examples from Jess Berenson-Shaw, who's a great communications person, about how to talk about these difficult problems like climate change, like anti-vaxxers, in the way that you talk about it to engage people, and not by starting off with the problem, but starting off with the aspiration and kind of working through that. So, yeah, communication is something that we're not specifically taught about, but there's a real art and a science to it. Okay, other questions? Yeah, thanks.
So bringing everything together that we've kind of discussed today, and we've talked about climate change, we've talked about global pandemics, everything is coming down to attitudes and understanding, right? And so when I'm thinking about what everything boils down to, we're talking about core beliefs, value systems that underpin all of our attitudes, which are the things that feed inequity and everything. So to me, this speaks to us needing to educate our children really early on so that they can make informed decisions, because that changes the long-term health consequences. That changes our choices on what we put into our bodies, affects climate, right? So what do you think that we can do as healthcare professionals to help educate the young people in society, and even bringing what we know to schools and things like that? Does that make sense?
Okay, so the question is what can we as health professionals bring to influence sort of the wider attitudes, is what you're talking about, the prevalent attitudes within the... And attitudes are developed, aren't they, by the narratives that come out from government and from leaders and so on. Right, narratives.
Oh, this is a tricky one. Look, children are brought up by a village, not just mum and dad. Society has moved into a place where sometimes we focus just on mum, dad, and that's it. If we're lucky, we might have granddad and grandma around. And I think to go back into the spaces where, number one, we have extended families, extended friends, extended networks to do a role that is not just for you as a parent or you as a health professional. We need to rely on each other to do that for us. Back in the day, you had a child that was out in the nightclub, for example, doing some naughty things. You'd have auntie and uncle pull you to the side and say, I'm going to tell your parents, now you behave. We sort of have let go of that behavior because it's not PC or it's not appropriate. When in fact, for me, if my kids were out doing something that wasn't appropriate or not something that we valued, I would expect my friends or peers or colleagues to help guide them. So I do think we need to start going back to basics, remembering what's really important. We are not the only ones that can inform and influence our children's lives, their values, etc. Everybody else has a role, and I think we need to try and strengthen that. Thank you.
I have a slightly different story, which is sort of related to my podcast and like social media stuff. So to your comment about, can we educate young people in schools about diet and all that? I think it's really challenging in this environment because there is this pernicious idea going around, and it's growing, I think, even amongst healthcare workers as well. I think it's a much bigger extension of the body positivity movement, where actually people are making comments like, oh, if you tell people what is a healthy or unhealthy food, that this sort of behaviour will encourage eating disorders, which I think is actually completely false. So, I've said things like, actually children do need to have education around what's healthy and what's not healthy. They need to be educated about, having a balanced diet of fruit and vegetables and trying to avoid, pretty simple stuff like avoiding fizzy drink and processed foods and things like that. But you actually, even when you say this out loud in social media, you get backlash saying, oh, this is what causes body dysmorphia and eating disorders long term, blah, blah, blah. And people are going to have a bad relationship with food if you say this, because you're giving a moral idea of what is good and bad on food. So I think we absolutely do need to push back and say that actually there is such a thing as healthy food and unhealthy food, but you have to be cognizant that there's this pernicious idea out there, and you can look this up if you like. It's called Health at Every Size, which is a movement that is actually very antithetical to what we know about nutrition and medicine and healthcare in general. It's this idea that actually, excess fat is not bad for you, or that there's no negative consequence of people with excess fat, or that there's no healthy amount of food to consume, or there's no healthy amount of exercise to do. So I think that this is a growing movement amongst some healthcare workers and also amongst people in the sort of the social sciences kind of idea as well. And I think we actually need to push back on that. There's not enough people in medicine who are actually willing to push back and stand up against this idea that is saying that there's no such thing as healthy and unhealthy food. So I think we do need some more education there.
Thanks, Nina. Yep. Sorry, Maya? Yeah.
We were talking about that individual role. Don't forget the environment we live in. It's obesogenic. And the biggest stick that comes out, of course, is legislation and making sure that wherever our kids are living, they're not surrounded by shops that sell high sugar content foods, empty calories, etc. So I do think, apart from doing the education and colleagues providing that wherever the settings are, the environment we live in is probably the most toxic for our kids going forward. And we have levers that can push, that can influence this, but they are quite powerful in terms of the commercial determinants I mentioned previously. They're quite powerful. And so we need to do our bit to help in those areas. Thank you.
Thanks.
In Japan, all school kids get provided free lunch, and through the free lunch, it's all like done by a dietitian, and the kids get a lot of education on it. And then when you ask these kids what their favourite food is, they say things like broccoli and salmon, and that's highly aspirational, but it would be great if we could have that in New Zealand. But it just goes to show that you don't have to have bad food in childhood, and children will eat good food if you give it to them.
So just, I'll just come to you. Just drilling down from what you're talking about, the obesogenic environment, when you get down to it, it does come down to mindsets. So for example, if a KFC wants to set up next to a primary school, what is the law or the regulations or the zonings that will allow that, and can the community object to it? They can't object to it on health grounds. They're not allowed to within the law. There's no space for that. You know, commerce kind of overrules the community's objection to the next KFC next to the primary school. So you drill down deep enough underneath these environments, you'll come to those mindsets and the differences in mindsets you're talking about. Sorry,
and exactly the same way as alcohol outlets close to schools, alcohol advertising close to schools, and vape shops close to schools. And by advocating against it, we found that there was consumers really had no power against these alcohol laws and council bylaws and councils, because they had all the alcohol lawyers involved.
Yeah, but down to the mindset about what trumps, you know, and commerce trumps local concerns about health. Yeah.
So I just think that central to many of these conversations we're having, especially with the direction of being able to trust what's coming out in our literature and stuff on social media, is being able to distinguish fact from fiction. So I wondered, your guys, from your perspective, as public health experts, what's a lens, what's a framework that we can apply to any information we're presented with in order to have the confidence to determine the truth and to communicate that and have the confidence to communicate that?
Okay, so a question about the framework for dealing with misinformation and disinformation and how we might deal with it.
I'm going to have a go at that. You use the gate frame. Do you remember triangle, circle, square? So for the triangle, you want to know what population, where did that population, how were they recruited, what proportion, you know, is that generalisable to the people that you are treating? You look at the intervention, what type of intervention, is it multifaceted, how did they used Rambo recruitment, maintenance, bias and blind objective outcomes. You look at what outcomes over what period of time. You look at the study design and see if it's the best study design for your question. So you're using the PCOT framework, participants, exposure, comparison, outcome, time. You guys know all of this. Keep it. It's just the most practical framework to think about the evidence.
I think also what's really challenging is the amount of research that's being pumped out. So there's far more journals now than there were 40 years ago. So much is pumping out. And as an individual, it's going to be very difficult to do a gate frame on every single paper. But that's kind of all you can do, is go and actually read the paper and explore the citations. Because sometimes when I have to do like a journal club presentation or something, and you read the article and you're like, oh, crap, like this citation is citing something, which is citing something else, which is citing something else, citing something else, and you realise that there's just all these papers that cite each other, and it's just, very circular, and you're like, is the science sciencing? And you're like, I don't think so. That's an F. So I think, we need to slow down with looking at the research, and it comes to like a wider problem, I think, in academia, where there's this, what people are talking about, this publish or perish kind of mentality within the wider science as well, where people are being pushed to publish, and also publish new science instead of actually going back and checking whether previous science was actually correct, because we have a replicability problem as well in science, where you actually are struggling to replicate the same results with the same study design.
So look at meta-analyses.
Yeah.
Could I just add, one of the important things, every time a paper comes my way, I'll read the abstract, then I'll go straight to methodology, and that's where you get your PCOTs, and try to look for gaps. that they may not have considered. Otherwise, you could be friends with our colleagues here, Boyd and others that also have lots of experience in this space. But as a young person in research, I don't know, I did a systematic review as part of my PhD, and I had this thing that everyone should do it. As a medical doctor, luckily I don't influence the curriculum, but I found the discipline really important, and it's held me well going into the future in terms of understanding how papers are published, or methodology especially, and all the hierarchy around evidence, etc. So, yeah. Systematic reviews are good.
Systematic reviews, yeah. Everyone should do one once at least. Okay, any other questions? Yeah, Anna's got one from somewhere.
Okay, we've got one going back to what we were talking about before. Student is wondering if you think the language around healthy diet and lifestyle needs to be changed. It seems like even the words diet and lifestyle have bad connotations these days.
Who wants to tackle that?
Can you ask the question again?
So the question is, these words of diet and lifestyle, are they the right words to use, and how do we, to describe what we're wanting to get across? Is that the story? Bad connotations, yeah.
I think the issue is that if we keep changing the language, we're going to end up with another word that people have negative connotations around. I think the fact is that people are eating worse food than they were 30 years ago, and people are not moving as much as they were 30 years ago, and that's pretty clear in the rates of obesity and all the negative effects of obesity as well. So while I know that some people have bad prior experience with dieting in terms of the word diet, when we talk about people going on a crash diet or something like that, I think if we keep bubble wrapping people around in these words, we're just going to end up with another word that people are going to not like. What's another word for diet? The things that we eat, and then people are going to start being worried about the word eat.
Yeah. I mean, I do struggle with the term lifestyle, I have to say, because I'm a member of the Australasian Society for Lifestyle Medicine, and this is clinicians who try to use a wider view of treatment options with their patients, but it kind of still lands the problem within the individual, doesn't it, and doesn't really acknowledge the wider environment that's influencing those behaviours. So I think lifestyle is a challenge. I wish we had a better word.
But I think that it goes to one of the slides that Sue had put up as well. It was like 10% was environment, 40% was socioeconomic factors, but there's a 30% that is lifestyle factors. And I think in public health we always talk about the environmental factors that are outside of people's control. But I think what we've done as well, I think in the last 10, 20 years, in my view, is that we've actually disempowered people to think that there's no way that people can make changes on their health, when that's actually completely false. You just have to look at movements like BLM, BBM. So Dave Latele down in South Auckland has started a movement called BBM, and he's getting people who are, I'm saying morbidly obese, like people who can't get out of bed, kind of morbidly obese. He, in his program with diet, exercise and community, which is the big one, community and purpose, has gotten these people up out of bed, walking and working out in the gym. And if that's not an argument to say that lifestyle factors in terms of getting people to change their behaviours is important, then I don't know what else is.
Okay, we're going to finish on that very positive note of Dave Latele in South Auckland, because he is a total champion. He is changing the dialogue. He is changing attitudes and actions in South Auckland and West Auckland. So with that, can I just get you to thank very much these three wonderful presenters. And before I give them their box of chocolates to add to their diet, just a reminder that we're back here at 1 o'clock, so you've got a quick lunch, and those of you online, jump onto the same link. Thanks.
Thank you.
Thank you. Thank you. Oh my God, I love
Have you taken the presentations off here? Okay. Righto, folks. Plenty of seats down the front, girls. All right. Wow, that was a spectacular morning. Gee, hearing from those three people, Michael with all of his huge experience and not only in the epidemiology and research, but then also in the whole communication space and dealing with government. And then these last three speakers from their perspectives, quite different work that they've been doing, and really quite a wide variety. I thought it was just fantastic. So you're very fortunate to have heard all those people. I probably talked about most of this in January, but then it was too far away and you probably didn't pay any attention. So I'll be going over it a bit more because it's going to be something you're jumping into from today. All right, so this is today's session, talking about the timetable, expectations, project distinctions, and then we can have any questions. At 3 o'clock, you'll be meeting with your group facilitators. And then tomorrow, Population Health in Action will be in your regions. Auckland people will be here. We will have zooming in for those rural placement students. And also we'll be zooming in for Pukawakawa tomorrow. That's because in Pukawakawa and Northland, they're very short of public health physicians, and the only one who's fully employed up there will be down in Auckland having a scan on her pregnancy. So she's here, so she'll be joining us. Carrie Byers will be joining us tomorrow, and the Pukawakawa team will be zooming in, and we have two other public health physicians whom you'll hear from. The rest will be face-to-face in your regions. And then from Tuesday afternoon, Wednesday and Thursday, you'll be meeting with agencies, doing your research topic, developing your project and presentation. And each day we'll have a Zoom Q&A with me to just go over any issues. So one person in the group should be kind of nominated for that person. It kind of counts. Seeing me 3 times counts as an agency visit. You'll actually hear how the other groups are doing, the struggles they're having, the things that they're coming up with. So it's quite a lot. It's quite interesting actually hearing how other groups are doing. And then on Friday, we're presenting all our stuff. So let's go through this. Righto, so PHI Week is compulsory, folks. So you need to attend all of the sessions. There is this year a slight overlap with NZMSA conference in Christchurch. A few people going to that, are they? From here? Yeah. We have worked with NZMSA on trying to make this work for both. I think for people who are going, we'll be leaving very early in the morning on Friday morning, because that's when the cheap flights are. And they'll be getting into Christchurch, and there'll be a place for people there to go, and I think in the library or some rooms they have booked there for you to go and be on Zoom for the presentations or any other work that you need to be doing with your group before we start and on the presentations. So those people should have filed leave forms, and that's fine, they're being approved, but on those conditions that you participate, you make sure that you do all your group work, you contribute to your group, and you participate in the full activities for the presentations on Friday. Any absences, let me and Anna know. Big absences may require some remedial work. Teamwork. Now, it's slightly surprising that you guys will be working in teams for your whole lives, whole professional lives, but you haven't really had a lot of teamwork exposure during your training, and this is a really valuable opportunity to get into the teamwork and to learn about how teams operate and how they can work the best. And so while this is a team effort, your contribution is expected and assessed. So each person on Thursday will be submitting an individual form about the agencies that they saw, giving permissions to use filming if your group wins, so that the next group can look at you and see how well you did. But also to make a call on whether people pull their weight in the team. We don't want coat tailors. Okay, so these problems that we've given you are really tough. The solutions are even tougher. They have foiled lots of public health people for decades, and we're giving you a week to sort out a bit of a solution for part of it. So it's a big ask, but full engagement with the wider challenge, even though you'll just pick off one piece of it to respond to, getting to grips with the wider issues of the problem we're giving you, and what the agencies are doing is really important. So these agencies that Anna has set up for us, so everybody's met Anna, right? Anna's down here. She's the hero of this whole course. She spent the year organising stuff for you guys. This is a huge enterprise to get all of these agencies and experts all lined up. So it's a great privilege for you to be able to participate in this with all this work done. So Anna has set up meetings with agencies, and please be very courteous, as I know you will be, and attentive in dealing with the agencies and learning and understanding what they do, even if their area of work may not be exactly where your project is operating. This is still a learning experience for you to see who is doing what in the community in health, and so take it with that in mind. So we've got 27 groups, a little bit of a heterogeneity in size. So a couple of the groups are smallish and some of them are bigger. I think the rural placement guys have 12. We give you a topic, you don't get a choice. It's a group assessment. You do presentations on Friday, one winning team per stream. So Maz gives us, Maz and the New Zealand College of Public Health Medicine both give us a bit of money to give you some vouchers for the winners. And you'll have a facilitator who you're meeting with this afternoon. Now, the facilitator is a public health expert. They're not all doctors. A lot of people who work in public health are not medically trained. That doesn't matter. They know public health perfectly well and are experts in the area. But these people may not be an expert in your topic, but that doesn't matter because they're there just to help you navigate your way through the issues and the challenges that you'll have through the week. To try to get some cohesive group work, guide the development of your campaign or project, give you some positive feedback on the Thursday on your session. We'll be meeting this afternoon, as I said, and if you want to negotiate other contact with them, then do so. It's probably quite a good idea for one person in the group to be a contact with the facilitator, so you swap phone numbers, so you can just drop them a note to tell them how you're going or whether you need any help from the facilitator. So what we've told the facilitators is that they will see you this afternoon and they'll see you on Thursday for your practice, and in between times it's by negotiation. They're very happy to do that. Right, so these are the topics. Taranaki, Pukauakaua, Bay of Plenty, Waikato and the rural group on the left and Auckland ones on the right. So this is a tough set of problems. You've already heard today about some of them, the food and waterborne diseases and the vaccine preventable diseases and rheumatic fever. We've talked about obesogenic environments. People mentioned tobacco and vaping, climate change. So there's a lot of really broad topics there. Some of them might seem a little bit wacky, a little bit outside direct health, but they all have health consequences. Those of you in Waikato who are doing disabilities, this is the first time we've run this topic. So we would really appreciate your specific feedback and the feedback from your facilitator on how that went. Disabilities is a very big topic, but a really critically important one. The Rural Mental Health Team, this is our first shot at doing that with your placements in the various small localities where you'll be staying over the period, and you'll be doing everything online. Kyle Eccleston will be your facilitator who runs that course. So also important feedback from you about that course. So those are the topics. I should just say problem gambling. The problem gambling group, your facilitator's a bit crook today, Rebecca. So I'll just help you with that and getting started this afternoon. And then Rebecca will take over after that. And I don't think I've got anything else to add from the other ones specifically. Okay, tough topics. You've got the list of agencies. Now we call them agencies, and some of them are NGOs, community organisations, public health units. They might be in Te Whata Ora, schools, local government, that sort of thing. So we just lump them all under the umbrella of agencies. Somebody in the group needs to be appointed as the person to contact the agencies. So Anna has organised the time and the day for your group to meet with them, but they need confirmation calls this afternoon. And those of you that are meeting online, you need to, the person who's responsible for this needs to set up the Zoom link. We can't do a Zoom link for 27 groups simultaneously with our one Zoom link. So you have to, whoever's responsible within the group has to get in touch with the agencies that they're meeting and set up those Zoom links. When you meet with the agencies, it won't be the whole group. You know, you'll allocate, you'll divide and conquer. So it'll be a subgroup of your group meeting with the agencies. We've got a set of questions that you can guide you. They'll tell you a bit about what they do, but then there's some guiding questions that you can use to help understand what they do and how it might help in your campaign. And remember, this is all time they're giving to you, so I'm sure you'll to create that Zoom link. The topic expert will give you an hour of their time and go through it, but we've also warned them that if you have other specific content areas that you could get back in touch with them, so use that if necessary. On Canvas, we have a reading list of relevant papers, reports, websites, that sort of thing. So some of the people in your group will be the researchers, and they'll have their head down into the data and looking at these reports and pulling out the information from the literature that's relevant to what you're doing. And you make arrangements to meet with your topic expert, with the Zoom arrangements with the topic expert. Okay, so the assessment is just a pass-fail. And what your assignment is that you have to create a compelling project or / campaign. People don't really quite understand what we mean by campaign, so we're talking about it like a project campaign to improve an aspect of the societal conditions or systems or something related to the problem, upstream in the problem. Could be a cause or a driver, a barrier to action, a policy action. Lots of various pieces of the determinants are at play here, and you need to choose one to do it. You do need to submit reports, and I'll talk a little bit more about what that campaign means and looks like. There are some reports you have to submit, so we want a group written report. We don't want a thesis, just 1,000 words on the outline of the campaign. And if you can submit that by 5 o'clock on Thursday. The individual worksheets, as I said, which says what agencies you went to, commentary on the workload, distribution and permissions by the same time. The group may be working still on their slides and presentation on the Friday morning, but can somebody be responsible for submitting on behalf of the group a PDF of the slides? And then the oral presentation is where the pass-fail is. So you'll be allocated into 5 streams, and from about 11 o'clock, we start about 11 o'clock. There's 2 streams have got 6 and 3 have got 5, something like that. So the ones who have 6 start a bit earlier and go through. Then we have a lunch break. Then you finish those presentations, and then you have a bit of a break where you fill in the feedback form for us, and while the assessors are ranking up the scores and letting us know, and then at the end of it we have another Zoom session, a quick Zoom session at the end, just to let you know who the winners are. One winner per stream. I'll talk a little bit about the presentations later. Distinction. Population health is twice as good as all the other disciplines, so we've got 2 population health prizes. Those of you interested in going for distinction, you have the opportunity to do either a creative work, a poem, or a piece of prose, or something artistic, or you can do an academic essay on the topic. And we need to get that by the 30th of the 6th. So we look at those, assess those, and the top ones get awarded distinctions, and the top from each of the creative and the academic streams will get the population health prizes. And the academic essay, we work with the New Zealand Medical Students Journal to promote it for publication in the journal. So if you're writing, doing the academic one, and you win that, then it's a real bonus to get that into that journal. That's good for your CV. And I think they take some creative works as well, but certainly the academic essay. Righto, the groups. You need to get organised early, and that's what we'll do this afternoon. You're getting oriented to the timetabling and seeing what agencies you're meeting, organising those Zooms, the person who's responsible for that. So the organiser type people will be good at that. There needs to be chairperson or chair people who help manage the process and run the group. So the chair is not the bossiest person. It's the person who runs the process, gives everybody a fair chance, and just manages how that process goes. People who dive into the literature and pull that out, people who liaise with the facilitator, people who come along to my midday session, people who liaise with the topic expert. You might want to liaise with Anna. So just allocate some of those roles. Some of you might be good at report writing, so somebody needs to write that 1,000-word report. Taking notes in the meetings, developing the slides, doing the presenting, answering the questions, etc. Lots of different roles. Typically, the one that most people shy away from is the presenting and responding to the questions. I'd really encourage you to put your hand up for that role. That's, as Michael said and the other speakers said, you know, your voice is going to be critical in your career and for health in New Zealand. And your voice, some people are naturally born with a gift of the gab, but a lot of it is practice and being able to stand up and articulate it. So I'd really encourage you to give that a crack and don't be afraid of that. Okay, so we'll decide on some roles this afternoon, but be flexible and be constantly communicating with each other. Set up a WhatsApp group or whatever. Okay, then we're going to go through this process, this forming, storming, norming, performing process. And these are quite deliberate steps in getting, in a short space of time, to some outcome. So the forming is orienting yourself to the task. What the hell are we here to do? And to the people in the group, and moving from your kind of individual space into the collective space. Then the storming is the brainstorming part, where you're open to ideas, you're chucking ideas out. Wouldn't that be a good idea, or should we do something here? This is not a time to rubbish everybody. This is a time to be open-minded, accept ideas as they come in. That's part of the sort of rules, if you like, of brainstorming. And just gain trust with each other, show a bit of tolerance. Then you're going to need to be cooperating pretty early and norming, coming down and converging on a collective campaign on Wednesday, largely, as all these ideas come back from the agencies and you're tossing them around. Okay, you're going to have to start conforming to that, and whoever's chairing it is kind of running the process and trying to help these ideas come out. And then obviously you're going to have to perform, polish your presentation, get constructive critiques from everybody. So learning yourselves how to constructively critique other people's presentation is a good skill to have, and your facilitator will help you with that as well. Righto, presentations, you've got 15 minutes to present, so practice your timing on that. In general, about 12 slides. All the usual things apply to PowerPoint slides. Don't take my slides as exemplars. They're pretty old school. You can do way better than me, but don't fill it all up with lots of text and lots of animations and that sort of stuff. But make sure it can be brightened up a bit brighter than mine. One or two presenters. Now, if you can get presenters who can tell the story. This is a story you're putting. You're trying to persuade the panel, and the panel consists of Julie and Mafi and me and Matere and Carrie Bryars and all those types of people sitting on this panel like we do for Maz Foundation, and you're trying to convince us to give $1 million to the campaign that you've devised. So it's a cell project, and you're telling the story, and so you need to get the evidence over as well as the narrative, as well as the emotion actually, and the innovation. So I know it's hard, but try not to read the text. And look into the camera when you're doing it. This will all be on Zoom except for the Waikato people. They'll be presenting face to face, but it'll all be on Zoom. So if you're just looking into your thing, look at the Zoom camera. Don't wander your eyes all around the place. And then you do your presentation, and then there'll be Q&A from the other students in the stream. So think up your questions for the others who've just done their presentation. Think of the curliest question you can. Try to put them off their guard, get them into thinking, and that's part of your training as well, is to think about what questions you can get to them. And one winning team per stream, and you get a bit of a voucher at the end of it. All right, health philanthropy, we've heard about it already. They've got $1 million. They want to contribute it to a concerted project or campaign that can make a real difference to something about this health problem that you've got, or an aspect of it. And you've got to convince them that you have worked out where there's some leverage for change, if only some resources could be applied to it. They don't want to fund campaigns that are targeting those individuals with the health problems, with the rheumatic fever or the dental caries or the alcohol problems or the smokers or whatever. No, this is at the upstream end of it. Now, that's that can be a challenge, getting your head into that space, because it's a new space for you. And some of them that are quite clinically focused, rheumatic fever and oral health is a good examples. You've got to be thinking upstream, and Michael gave you some good examples there. So what do we mean by a campaign? And it's a little bit like a project, but a campaign has more of a sort of a persuasive element to it, I guess, because you are pulling together the evidence and the rationale and the aims and the target groups. There's a lot of thinking to do. Who are your allies? Who's going to be the opposition? Who are the agents, the change agents that you want to tailor your messages to? What strategies and actions are you going to do? How are you going to measure success? Timelines, budgets, impact, all that sort of stuff. So this is really about planning how you're going to create that lever for change in the upstream space to do something about your problem, about the problem you've been given with. And it has a start and an end. So here's some examples of strategies, and you've even heard some of that this morning. Just thinking about Michael and the Campylobacter. Get your evidence. Thinking about Sue and pulling all that amazing evidence out of the PHO and starting with the evidence. Where is the problem? Where are we going to target? Honing down on that. Building relationships and networks. Michael talked about the relationship with the New Zealand Food Safety Authority, and Moore talked about all of those relationships that are really important for getting health underway. COVID response in the Cook Islands, bring all the leaders in, get them on board so they can go out and so on. Convening the allies, like I've just mentioned, knowing who your opposition is, where's the pushback going to come from? Create formal coalitions if you want, where there's a sort of agreement, memorandum of understanding. I've got some examples of that on the on Canvas. Then you've got to develop a whole bunch of materials and develop and disseminate the messages. If you're going to go down a policy track, what's this policy that you're wanting? Then you have to advocate for the policies, monitoring and accountability systems. There's a heck of a lot of pieces to this that you have to be able to convey in 15 minutes. How are you going to influence the culture of an organisation? We talked before about mindsets and attitudes. Well, organisations have cultures and mindsets as well, and sometimes that's a problem that needs to be changed. Champions, training programs. I've put apps in brackets. Try and avoid apps if you can. We're trying to think a bit deeper than that. So, but lots of areas. Sometimes people think, oh, gee, I've got this huge problem that we're trying to deal with, and we can't do it all. And we've got a good idea for an intervention, but we don't know if it's going to really work or not. We want to try and test it out, and then that could be scaled up or used more widely. That's a plausible way to go, to have a demonstration project. But if you're doing the demonstration project, you still have to identify what is it supposed to achieve, how are you going to measure the impacts, why you're doing a demonstration, what are you going to then show, what's that going to lead to when you scale up, and so on. So yes, demonstration projects are one way of fitting these big problems into your head and doing something about it, but that needs to have quite a bit of monitoring and evaluation and thought about the rollout after that. Okay, so there's on Canvas, we've got a presentation and campaign details on there for you. We've got the presentations from the 5 winners from last year. So take a look at the types of presentations they had. But if you're in the same group, don't plagiarise the same idea. We know what those ones were that won. So, but you'll get an idea of the quality of it. There's a recorded presentation on Canvas, and we give you a budget of $1 million, which is not a lot of money. It's like a few years' work for a handful of people, basically. So it's not a lot to be able to achieve leverage. And people do fall over a little bit in saying how detailed does this budget need to be, and so on. The reason for just putting a general limit on this is that we don't want you to go buy TV ads, because you'll burn that up in a half a dozen ads. So this is about people engaging and trying to make a difference. So, people cost 100 to 150k. There might be materials. If you want to do an opinion survey, about $1,000 a question. Lots of bits and pieces, resources and things you might need. Just put numbers in it. We're not expecting an exact budget, but just in that ballpark, so it doesn't go totally overboard. But that's the sort of size of expectation. This is the marking rubric for the presentations, and that's up on Canvas, so you can take a look at that. And when you're pulling your slides together in your presentations. Have somebody dive into this rubric and pretend to be an assessor and do the assessments and see where your marking goes, see where they are strong, see where they fall down. So use that. All right, I've mentioned about confirming appointments with the agencies. And what counts as an agency visit is, because you have to do 3 of these. So an agency visit is meetings. The one tomorrow will be quite quick because you've hardly got into it, but that'll just be us getting to grips with each other, and if you've got any quick questions, we'll just do a quick round with the group and any questions you've got around divvying up jobs or that sort of thing. So that'll probably be quite quick tomorrow. Wednesday and Thursday, when you're getting into the meat of it, we will be, that might take a bit more time. So our experience is it takes more than an hour. Now this is actually, for those people who are the reps for the midday meeting, this is actually quite interesting hearing the struggles and the issues and the questions that the other groups have. So you're more than welcome to join in those, but just to make it a bit efficient, on Tuesdays and Thursday we'll do the Auckland groups first. So if you're in the regions, you can pop on a little bit later because it'll probably go through till at least 1:30. So that's for those midday meetings. I've mentioned respecting the time and effort that the agencies are putting into that. I've mentioned the individual reports and the resources on Canvas. Right, now I'm going to go back over some of these models, some of these frameworks, because you'll find some of these are useful in the way that you hang your project together, the way you hang your talk together, the way that you convince the panel that you've got all the bases covered, and just give you confidence that you've got all the pieces of the puzzle together. So first up there is Te Tiriti articles and the Te Tiriti principles and the Te Whare Tapawha. So quite a few people use that. It's a nice, holistic, comprehensive, structural, but relatively simple model to get in your head, and it's a good one to use. You don't have to just stick with one. You can have different ways of thinking about these things. So you don't have to just choose one or any of them, actually. The characteristics of population. So these are just the sort of the curves of different of the infectious diseases that comes through the population. But Sue gave you an excellent demonstration of the characteristics of the populations, and looking at those patterns tells you where you should be targeting. Thinking upstream, nobody's going to leave the end of this week without knowing what upstream means. If you don't know, there's a little YouTube video there, but it's basically finding out who's chucking the kids in the river, not the people who are doing the rescue. Understanding equity and equality. So there are different ways of thinking about this, and the set of pictures on the right is how it's often displayed. So you have 3 people with different characteristics, but they are facing the same barrier, and that disadvantages some than others. And equity is about giving them differential resources or treating them differently. Don't tell David Seymour this. Treating them differently so that they have similar outcomes. Then taking it even further to what we have with the reality of the big social divide, socioeconomic divide in this country, and then liberation. Now that's one way of thinking about it. Some people don't like that picture because they're saying that the inequality or the inequity is due to some individual characteristic, like shortness. But what's the inequity is not that the guy's short, but they're all the same size, but one guy's standing behind a taller fence that society has constructed. So the inequities are often external and not individually developed. So think about that. These are just mental models. You've seen this one already about pushing the individual burden and the societal impacts around reducing societal interventions to reduce the slope that burden is that people have to carry. The socio-ecological model, this is one you've probably come across. Folks come across this one? Yeah, this is really helpful. This is understanding that the person that's coming in, that you see at the, in front of you in the clinic or in the hospital, you see the individual, but you know because of this model that they have onion rings of layers of influence around them. And so it's not just the individual characteristics that you have to manage, but it's also the wider influences on that individual. So that's really helpful, a really helpful framework for clinical care, clinical health. For epidemics and pandemics, it's not so helpful. And in fact, it might be better if we turn it inside out. And this is one way that we did it with the Lancet Commission on Obesity. So you flip it inside out. And you say the most important thing is actually not the individual, it's the thing right in the centre, which are the natural systems upon which we all depend. And then wrapped around that are all these man-made or human-made systems that we have created. And the most important ones are the ones right at the centre. The governance, who's got the power, who's making the decisions, who's dictating the policies, who's allocating the funding. So that's the most powerful, and then that flows into the macro systems like the food system, that flows into the meso systems like your supermarket, that flows into the micro systems like you and your interaction with the supermarket and with the environment and your networks and so on. So this is more of a population way of thinking about those onion rings. And these are the 4 outcomes that we want from these human systems and from our natural systems. Ottawa Charter, you've already heard this presented a couple of times today. It's an oldie, but it's a goodie, 1986. A few people probably weren't born by then. Anyway, it was quite a revelation when it came out, I have to say, and it was it was a structure to show how we treat population problems in a different way. So strengthening community action, developing personal skills, creating supportive environments, reorienting health services, but actually this should be reorienting any services or reorienting agencies, reorienting systems out there. It's not just health services, building healthy public policy, and all the while enabling, mediating and advocating. So that's still a really useful framework. If you're going to do a project, then people often use these logic models, these program action logic models. And so you start off on the left-hand side and you work your way through the right-hand side. What is the situation, the needs, the assets, a little bit like you heard from Sue, you look at the data, then you work on your priorities, and again, she went through that and she said, okay, these are our priorities for the preschoolers, these are our priorities for children, these are our priorities for youth, and so on. And you get your mandate she got a mandate from the PHOs, and the values and so on, the collaboration. And then the inputs, where we're going to get the money from, who's got the expertise, who's got the materials, and then the outputs, who do we reach, what do we do, what do we create? These are all the strategies that you use. And then the outcomes, what's going to happen, what do we think is going to be the first thing that changes in skills and interest and knowledge, then changes in behaviour, and then changes in health outcome. So you do need to have this pattern in your head of why you're trying to do something flowing through that. Now, this is really helpful. It seems quite detailed there, and sometimes projects like this do need to be quite detailed. We're not expecting a detailed plan like this, but at least this should be in your head and we can see your logical thinking. Now, this is really valuable, but it's not the totality of the problem, because actually things don't tend to happen in a linear fashion. We're dealing in systems and they happen in a systems fashion. And I gave you a little talk at the beginning of the year about systems thinking, because problems are circles, problems are loops, problems are things that relate to each other that maintain themselves or block change, the feedback, the balancing loops. You try to do something and you get pushback. So it's not just points in time as root causes, it's loops that are creating the problem. And you need to be able to understand those loops really to be able to understand how you can interact with those loops. So for example, in fact, going back to Sue's presentation, they got the data at the PHO level. They did their work on developing what the priorities were. And then they closed the loop by taking it to each individual practice and giving them their data and giving them their progress on how they're going, so that it's fed back to the people that are making the decisions. So things like that, closing the loop, are a great way to really break into some of these vicious cycles. So, and the knowledge one is an easy one to sort of think about, but all problems that are sitting in society or even within the healthcare system that we struggle with are circular. And you have to understand that circularity if you really want to make a difference. And we talked a bit before about attitudes and beliefs. Yeah, right down the bottom is the mental models. So there might be cultural, attitudinal things that might be at play there, and how do you make changes there? Social determinants of health. So this was this 2008 WHO report by Sir Michael Marmot was foundational in lifting our vision into society for the health problems. Now he called it the social determinants of health. Personally, I would have thought societal is better. Sounds a bit more structural. Social tends to be of the people, but societal is kind of more of the structures. But anyway, it's the same impression. There's different types of them. You know, the commercial drivers, the economic drivers, the political drivers, religious drivers. There's all sorts of underpinning determinants of health that are right down at the causes of the causes of the causes. Now, I should have mentioned this before. I want to emphasise this. The $1 million that you guys are pitching for to the likes of Julian Murphy are not for a group of fifth-year students to do the project. You're not doing the thing. You are listening to agencies, you're understanding what they're doing and what could happen out there. And jeepers, if only we could put $1 million in here, then that could really have an important effect. So you're the mediators, right? You've gone out, talked to the agencies, you've done the thinking, you've pulled the literature, you've done the pitch to the philanthropy, you've got the bucks. Who's going to do this? Well, it's not you guys. You're going to be in sixth year next year. You're not going to be hanging around spending $1 million. Who's going to do it? And it's those agencies so you need to identify who they are. And it's not just may not just be one. And this is one of the challenges in population health, that often there are multiple agencies involved in trying to create a solution. And how do you get multiple agencies involved, coming from their different perspectives, to deal with something? At the moment, for Health Coalition Aotearoa, we're trying to get a campaign going around school lunches. Trying to rescue these school lunches from the grips of David Seymour's cost cutting. And so we're Health Coalition Aotearoa, we have a health focus. But then there's Child Poverty Action, which has a poverty focus. There's New Zealand Education Institute, which has an educational focus. There's UNICEF, which has a general child development focus. All of these groups, we need their expertise, we need their names, we need their logos, we need their input, so we can collectively go to government and say, you've got to do X, Y, Z to the school lunches. Okay, so you've got a half a dozen organisations like that that come from different places, have different resources, different kaupappas, but you want to work on something common. This is the way you do it, this collective impact. So collectively, you decide what the agenda is. What's the problem you're trying to address? What's the shared vision for change? And those diagrams, you know, the flow diagrams or the system diagrams, to put it down on paper, are actually critically important to get everybody on board. Shared measurements, just like Sue showed us, shared measurements of progress and shared accountability. Mutually reinforcing activities, that means Health Coalition will do what it does well. UNICEF will do what it does well. CPAG will have, the Child Poverty Action will have its networks. It will do stuff through its outlets and its resources and so on. So, but you want to make sure that they're all mutually reinforcing. Continuous communication to help do that, and backbone support. So who's doing all the coordinating and convening, and that requires money. So sometimes this collective impact is a really cost-effective way of getting impact, because you are using the passion and the expertise and the resources from multiple agencies to come together and create a bigger impact than you could do individually. But it does take this structure to be able to create that. There is a discourse around who's responsible for people's health problems. And this whole personal responsibility story comes up. And personal responsibility is actually really important. Personal responsibility for your health is critical. And people do generally want to take personal responsibility for themselves and their kids, but sometimes it's harder than for others. And if you really want to get into the space development strategy goes to the facilitator. I'll ask Anna in a second if she's got any tips, any things I've missed out on. Any absences, please let me and Anna know. Anna, anything?
Alrighty, so boys covered pretty much everything, but there are just a few kind of housekeeping things that it's really important to keep in the back of your head. If I was the right way around, that would be useful. First of all, it's really, really, really important, I can't stress it enough, to contact the agencies today. I'm getting emails already saying we haven't heard from anyone, is it still happening? So they are expecting to hear from you today, even meetings on Wednesday. And like Boyd said, someone will need to take responsibility for setting up the Zoom links for anyone who's got Zoom meetings, and there are quite a lot. With Zoom meetings, or meetings in general, agencies have been told there will probably be only 3 to 5 of you there. So if you have a Zoom meeting, it's really important not to have the rest of your team in the background, because the agencies feel really disengaged with that because there's a whole lot of people milling about. So if you do have a Zoom meeting and you guys, whoever's attending those, make sure you do it somewhere else. There are rooms available. Auckland people, you people, can email me about rooms for during the days. In the regions, on Canvas, there's information about who to contact about rooms there too. But yeah, don't have a meeting with 2 agency people and 6 people behind you, because it's really off-putting for them. Keep in mind that this whole week hinges around external stakeholders. If they didn't participate, it wouldn't happen. So, of course, you'll be all respectful and everything, but just keep that in the back of your head. Also keep in mind that some of these topics can be quite triggering for people. Some people in your team may have lived experiences, so just keep that in mind. What else? Oh.
Booking rooms, the other groups' booking rooms, they do go through...
Go through the contacts. So like Caroline for Kawakawa, that's all on Canvas under the room bookings bit.
Okay.
Meeting schedules with the agencies are constantly changing. Over the last couple of weeks, I've made, I don't know how many different changes to your meeting schedules. So don't just look at it this afternoon and go, that's it. Keep looking at it because there's constantly things changing. Someone's had a flood, so their building, you can't get in one entrance that they want you to go on, so they want you to go somewhere else. So I'll update that in Canvas on your team meeting schedule. So keep looking at that. What else? I think that's probably about it.
Okay.
But yeah, heavily dependent on external stakeholders, representing the university. Have fun.
All right. You can see the size of the enterprise this is, guys. This is a huge enterprise over this week to give you this experience, and it'll be very rewarding for you. Okay, any questions or comments? If there's any questions from the regions, flick them through to Anna. She'll keep look at any questions from folks here. All pretty clear. All right, guys, one final instruction. Enjoy it. Okay, thanks, guys.